Welcome everyone to the World Allergy Organization webinar series, New Insights for the Optimal Management of Allergic Diseases. My name is Brian Martin. I'm the President-elect of the World Allergy Organization, and today's schedule will be divided into two major sections. Our first section will be on allergic rhinitis, and our second section will be on urticaria. And Dr. Motohiro Ibasawa will be your moderator for the urticaria section. We have three speakers in each of our sections. And so in our first section on allergic rhinitis, we'll look at why allergy is increasing worldwide, the management of allergic rhinitis in adults and children, and allergic rhinitis management during the COVID-19 pandemic. So I think this will be a very interesting session for everyone. Our first speaker today will be Ignacio Anzoátegui from Spain, who will talk to us about why allergy is increasing worldwide. That will be followed by Nelson Rosario and Philippe Raoudi from Lebanon. Dr. Anzoátegui's talk is going to be about allergy and why it's increasing worldwide. And I would like at this point to introduce Dr. Ignacio Anzoátegui.
Good day. It's a great pleasure to participate in this webinar sponsored by Sanofi and entitled New Insights for the Optimal Management of Allergic Disease. The title of my presentation is Why is Allergy Increasing Worldwide? And well, we know that the allergies represent the most frequent chronic disease in Europe and affects almost 150 million people. And also these studies have shown that up to 30% of the population suffers from allergic rhinoconjunctivitis, 20% of asthma, and 15% from allergic skin conditions. And also we know that the allergies induce the increased use of health services, hospitalizations, pharmaceutical costs, billions of days of lost productivity through absenteeism or presenteeism. So when the people is going to work, but is being unable to perform properly. And this is estimated that the annual cost of asthma is over 18 billions, and the allergic rhinitis, according to Gallen, is over 100 billions euros. So it's really, really huge quantities. We also know that the allergies has a great impact on the families, on the quality of life of the families, but also on the own patients. And the allergies affects the personal development, the career plans, the lifestyle choice, may affect also the sleep, the mood, the school, the work competence, the social interaction. And also we know that the allergic people have higher risk of developing depression because many times these diseases are persisting or lasting for long periods. And the impact of allergies on the quality of life can be as high or even higher than those diseases commonly perceived as being more serious. And also another important factor in this article that is a systemic review of measures of disease severity in rhinitis, we can see how the symptoms persist even for 20 years in many of the patients and affecting the quality of life. So it's really lasting for long periods. But why allergy is increasing? Well, what makes to be allergic? Well, we need to have a genetic makeup that predisposes us to allergy and also to be exposed to the adequate environmental stimuli. And in fact, here we publish these interrelationships that we have between the contamination, the phenotype, the genes of the patient, and also all the environment exposures that the patient has. The fact is that we know that we have so many genes. It's not only a single gene for allergy. So we have genes that predispose to atopy, genes that predispose to airway hyperreactivity, genes directly modulating response to environmental exposures, genes regulating the immune response, genes determining the tissue response to chronic inflammation. So according with the number of the genes that, that are prone to develop allergy, if they are high, we call those patients or those subjects atopic. So atopic is the subject that is susceptible with a high probability to suffer allergy. And when we try to study if there is a combination of the genes and the environment, if the genes has not changed so much, because actually this is not so easy and it's not so fast, the change in the genes, maybe what has changed is the environment. And now the question is, has the environment changed in our lives? Before, probably most of the population was a rural environment, and now it's urbanized. And in fact, if we check how was the change in the pre-industrial lifestyles, most of the people were rural. The practice were occupational practice were farming and agriculture, mostly outdoor activities, poor hygiene, poor hygienic conditions with close contact with the stock, farm products, high rate of parasitic and bacterial infections, poor insulated and heated houses. So we were living in weather-influenced indoor conditions. Nowadays, we are more urbanized. The occupational practice are industry, manufacturing, technology. We have a lot of indoor hobbies. Our children many times playing a lot indoor instead of just playing outdoor. Most indoor activities, high level of hygiene, low rate of parasitic and bacterial infection, better heated and insulated houses, constant indoor conditions, but overall, we have now stress and outdoor and indoor pollution. And stress, we know that the stress enhances the allergic response. Actually, under stress conditions, the will and the flare is much higher. So if we make this graphic comparing the expression of allergy and environmental stimulation, and we add the stress, we could say that the stress makes allergy worse. And so at the end, what we have is not only the stress, we have also the maternal transmission, even the stress of the maternal transmission, the diet, the ozone, the air pollution, the tobacco smoke, the pollen smells, the medication, antibiotic, pests, pets, dust mites, microbiome, everything creates the exposome. And that will condition it, who are the subjects that will develop allergy or not. And one of the important factors that was discovered was published in Science many years ago when two groups of children, one group of children were from the Northern Europe and the other children were actually from Gambia and Nigeria. And both children were sensitized according with the allergens. They were resulted positive for the allergens. But meanwhile, the children that were living in the Northern Europe were suffering allergic conditions like asthma and allergic rhinitis. Those children in Gambia and Nigeria were sensitized, but they were not expressing allergy. They were not having symptoms. So, well, it was something else. Then I started to see that they were not so easy, the immune response. And in fact, in that moment, it was discovered also very important things in the antigen presentation process. When they capture the allergens or the antigens to be presented into the cells, there were other factors that were so important. Factors that we call like the PAMs, that they are the structures that are in the pathogens, and some receptors that they are the endocytic pattern recognition receptors. What is the difference? Well, these PAMs usually are typically highly conserved, essential components of the microbial structure and the metabolism, and the PRR are the receptor of these cells of the innate immune system, and they are able to recognize that PAMs. And why this is important? Well, it was shown that the pathogens play a specific role even in the allergic sensitization, because when we have pathogens, we stimulate also the TLR and we induce production of a profile Th1 cytokines, mainly IL-12 and IL-18. So at the end, with interferon gamma, we will produce Th1 profile, so not allergic. Meanwhile, if we have elements or allergens that are also some antigens, but they are not able to stimulate the production of IL-12, IL-18. What they produce is IL-4, IL-10, and at the end, what we have is a Th2 response. So that was the hygiene hypothesis. That was David Strahan, the first one that proposed this. And then later it was some discussion, but nowadays it's very highly accepted. In fact, what means the hygiene hypothesis? So we have this environmental exposure with microbes and allergens. If we remove the microbes, then we will go towards allergy. And this is the bias that is important. And that's why living in a very clean environment without microbial exposure, we will have an increment of the allergy. And now we will just check how is the process of desensitization. Well, for many years, this slide, we only saw how was the response with the allergens. So we learned that when the allergens enter into, for instance, in the bronchial epithelium, they are captured by the dendritic cell and also the antigen presenting cell, and is induce a response that they induce a profile of cytokines 2, and these cytokines 2 will just induce the switch of IgE specific to the allergen. And this allergen actually is bound, sorry, this specific IgE is bound to the cell surface of the mast cells and basophils, and then they are like triggered. But there are other factors that we can see here that are like tobacco and some other exposures that will induce the activation of alarmins, that will increase and enhance the response with the participation of other cells, and at the end they will contribute to a higher process of sensitization. Well, this is the sensitization phase. In the second contact is when we have the allergy response. When the allergen become in contact with the, get in contact with the immune system of the sensitized patient, these allergens cross-links the IgE that is on the cell surface of mast cells and basophils and induce the granulation in a very rapid manner in acute phase, and mainly they are histamine, TNF-alpha, proteases, heparin, that are responsible of the symptoms of sneezing, nasal congestion, nasal and ocular pruritus, and watery nose. A little later, after a few minutes, there is also the release of the lipid mediators, prostaglandins, PAF, leukotrienes, and they will be responsible of symptoms of wheezing and also some bronchoconstriction. And after hours, there is the release of other kind of cytokines and also chemokines that will induce the mucus secretion and the call of eosinophils to the place, so the eosinophil recruitment. And this is an acute phase, but we know that the allergy response is in two phases. It's the immediate one and also the chronic phase, where the participation of the same reaction will induce activation of a specific memory T cells, the specific release of some mediators that will activate effector cells, increase the adhesiveness and vascular permeability. Also, the IL-5 will be mainly responsible of eosinophil infiltration, IL-4 and 13, also local Ig production, the IL-13, the bronchial smooth muscle contraction, and also mucus secretion. Well, this is responsible of bronchial hyperreactivity, the bronchial remodeling, but also of the persistence of the symptoms and the exacerbations. So this is the classical response that is induced by allergen. But for many years, when we were just checking in the books of immunology, we found that the innate immune response was almost nothing in the book. It was the first chapter and it was very, very short. But later, it was the development. So which is the role of innate immunity? Actually, 3 people received a Nobel Prize for this research. We have Bruce Blatter and Jules Hoffman, that they were trying to explain how was the activation of the innate immunity, or Ralph Steinman that discovered how was the role, or which was the role of the dendritic cell in the role in the adaptive immunity. But it was, of course, from the beginning of the immune response. And nowadays, we have other kind of cells that are from the innate immunity. So we have NK, ILC1, ILC2, ILC3, and we can see that ILC2 is like Th2. In fact, if we compare the cells of the innate response and the adaptive response, we could say that ILC1 is like Th1, ILC2 is like Th2, ILC3 is like Th17, and NK cells are like cytotoxic CD8. So they are very similar. And why this is important? Because in this case, the activator of these cells are not the allergens, are the pollutants, are the different substances that will activate alarmins and will activate this ILC2 that of course will collaborate with the Th2 cells and at the end will induce exactly the same response. So we have a T2 response, and this is very important in the allergic. So we could say that we have one part that is activated by allergens and the other part that is activated for pollutants. And why is this important? Because pollutants plus the allergen will increase the sensitization. Of course, in those patients that are genetically susceptible of suffer, and when they are exposed to pollutants and co-exposure with the allergen, will have a decrement of the epithelial skin barrier function, an increment of the oxidative stress, epigenetic changes, and also a Th2, Th17 response. And at the end, we will have an increment of the sensitization, the asthma, the wheeze, the allergic rhinitis, atopic dermatitis, and other allergic conditions. And in fact, that's what was very important, this study that is FEX Pulsar. So for this, it was used the chamber that is in Canada, in the Kingston General Hospital. And actually, it's a very, very nice chamber to do a provocation with allergens. Well, the chamber is very big because the capacity is up to 120 subjects. And as you can see, the levels of the different areas and at different times are very, very really homogeneous and very stable. And this is very important. So the chamber is really has been tried for so many years and is very well considered just to be very actually accurate. And what is the FEX Pulsar study? Actually, the patients were in 3 periods. In the first period, they were exposed to just the allergen towards the patients were sensitized, the ragweed. And after 14 days, the same patients are exposed to the ragweed plus the diesel exhaust particles. So the ragweed, the allergen plus a pollutant, the diesel exhaust particle. And in the last exposure, half of them received placebo and half of them received fexofenadine in order to see how was the effect of the antihistamine in controlling those symptoms. So this is what the people were breathing. In the first, we have the ragweed alone. In the second, the diesel exhaust particles, and the mix you can see on the right. Well, and the important thing is that after the screening and all the eligible criteria of all the subjects, we can see that in every period, the symptoms were not only collected during the time in the chamber, also after 12 hours, the patients were just fulfilling all the really all the cards in order to have all the symptoms also in the hours outside the chamber. And after a washout of at least 2 weeks, patients were tried to the period second and then to the period third. What was the most important thing that it was observed? Well, that when the ragweed is added, these exhaust particles, the symptoms are significantly increased. So it means that the pollutants is a clear evidence that is increasing the symptoms of the ragweed. And this was very important. What happens in the third? Well, this is the first evidence that we have that antihistamine, like fexofenadine, is able to control the symptoms of allergic rhinitis increase or aggravate by pollutants, in this case, diesel exhaust particles. And that is very clear when it's compared with placebo. So, and not only that, in every single symptoms was better the behavior of the fexofenadine 180 milligrams compared with the placebo in the rhinorrhea, in the sneezing, in the nasal itchiness, in the nasal congestion, in the itchy eyes, in the watery eyes, in the red and burning eyes, and also in the itching of the palate or throat. So it was in every single symptom. So the expulsor, it was very important because it was the first demonstration clear in the chamber that the pollution together with the allergen increase the allergic rhinitis symptoms. And also, and this is persistent even after they leave the chamber. Also, it was for the first time demonstrated that fexofenadine was significantly reduced the pollution aggravated symptoms, and that is what the importance of this study. So the antihistamines are also really showing to work when the allergic rhinitis is aggravated by air pollutants. So we have genetic predisposition, as we mentioned, and in the presence of the allergen, we may have the allergic sensitization. In the presence of the allergen, we may have the organ hyperresponsiveness, and of course, the disease. But there are some factors that we saw regarding the hygiene hypothesis that we maybe, if we remove, we will increase this process, or we have some enhancing factors, and overall the pollutants. And the pollutants are playing a specific role, as we have seen also in the expulsor. In fact, this was recently reviewed in the World Journal that you can access to this article, where we just express or show all the immunopathological features of air pollution and the impact on the inflammatory airways disease. And what we know is that the pollutants, as acute respiratory effect, increase respiratory symptoms, increase lower respiratory illness, induce asthma exacerbations, decrease the reversible lung function, produce airway inflammation, alter the host defense, and enhance the allergic response. And at the chronic respiratory effect, we have a decreased lung growth, we have an altered lung structural development, what we call bronchialization, and we have an increased lifetime risk for asthma, chronic obstructive disease, and lung cancer. But also will depend on what we are doing as persons and the importance of the host factors. So we know that the dietary intake of antioxidants may play an important role in modifying the effect of air pollutants. And of course, we have genetic differences regarding the different responses. What we know is that when we have the allergen plus the oxidative stress at the end, we will have more inflammation and we will have more symptoms of asthmatic, in this case, or allergic rhinitis disease. What is we mentioned is very important, the intake of antioxidants. So if we take a lot of antioxidants, we will be able to control the symptoms. But if we have not antioxidant activity, the oxidative stress will increase very much the symptoms. Why? Because in normal conditions, we produce the normal mediators, but when we, because we have good antioxidant mechanisms. If we have not good antioxidant mechanisms, the pollution will induce the production really of some mediators that are really harming for the immune response, and at the end will have the symptoms. And in fact, I would like also to mention this study that was conducted in Mexico, and they were using the ozono in Mexico City, and they compared the effect of the antioxidant diets, fruit and vegetable, and also the Mediterranean diet, and they checked the lung function test to check the spirometric values, and as inflammatory marker, they use the IL-8. Well, you can see that the fruit and vegetable diet, even with the ozone exposure, increase the really the spirometric values and will decrease the inflammation. So we know that the fruit and vegetable diet are very important just to help to prevent the effects of the pollution. Well, the Mediterranean diet was showing some benefit, but not as good as fruit and vegetables diet. Well, another concept, it's true that now with the rules that we have in our countries, we can control the emissions that are released from the industries, but it's not able to really to compensate the quantity of gross domestic products that we produce or the vehicle miles travel, including the planes and all kinds of vehicles. And that at the end, we know that mainly the vehicles is the diesel, and the diesel is the source we know that will decrease the Th1 response and will increase the Th2 profile, really induce the allergy sensitization. And that will be another explanation for increment of allergic diseases. And in fact, we know in this also study conducted also in Mexico that is an increment of respiratory symptoms and drug use in asthmatic children when they live close to the traffic, when they are living very, very close to the speedways and motorways. So we know that when they are so close, they will have more cough, more wheezing, and more use of bronchodilators. Really is very important also to reduce the traffic. Also, we know that the very traffic areas, like in this study conducted in Lima, that is a significantly higher peri-urban adolescents when they compare with the rural counterparts regarding the expression of allergic rhinitis. But also I like very much this study that is from the 18th, that actually they compare 3 avenues in Lima, and for 2 years, all 3 avenues, that is Abancay, Guillermo de la Fuente, and Cesar Vallejo, they were measuring all the PM2.5, PM10, SO2, and NO2. And after these 2 years, they closed one of the avenues and they measure again. So they close Abancay Avenue, and what was the result? The avenue that had the traffic control, the traffic cut, was very important because in this avenue, there was a reduction of the PM2.5, 62%, the PM10, 55%, the NO2, 65%, and the SO2, 82%. So it's really important to control the traffic. So the traffic regulation can contribute to the continuous reduction of different air pollutants, and at the end will be our health in this. Because what we are breathing is these exhaust particles that we know that they break the junction between the epithelial cells of the lungs and will facilitate the penetration of the allergens. And actually is known that with pollution is necessary 20 times less of allergen to induce the same reaction. It's not the same to breathe one pollen, as you can see on the left, that is clean, that one pollen plus pollution, as you can see on the right. And another important thing is the indoor air pollution. It's not only outside the house. In the indoor, we may have pollutants in the bedrooms, in the attic, in the garage, in the kitchen, in the living areas. All kinds of pollutants we are also exposed. And in fact, this was recently also reviewed, how are the air pollution and the indoor settings. And we could see that indoor pollution might be much higher than outdoor pollution. So because indoor we may have gases, particulates, toxic microorganisms, and we may induce all the immune response that we saw before with oxidative stress, inactivation, epigenetic changes, cellular and immunological activations. And also our children are more exposed because they spend a lot of time indoor. And also we know that they are really very important risk factors for respiratory allergy disease. And also depending on the development of the country, they are having similar but in different levels. So it's very important the kind of pollutants that we may have at home and the conditions. Another problem is the global warming. The global warming and what is happening, and actually we also have the greenhouse effect that normally the X-ray, the sun ray will touch the earth and will rebound outside the atmosphere. But when we have some chemical changes due to the pollution in the atmosphere, this ray will remain in the atmosphere, heating the atmosphere, and that is the greenhouse effect. And in fact, it's not only the pollution that we induce, it's also the deforestation that we may induce, what will increase the levels of CO2 and the levels of the temperature globally. And they may have a direct impact because we know that due to the human activities, the increment of the CO2 and the temperature increase the amount of pollen. We will have the pollen that is more allergenic. It will increase the germination rate. Also, we will have an altered plant tree distribution. The season will start before and will remain longer. So this is the effect of CO2 and temperature. And of course, we may have more in the city center, and when we are just leaving the city center, theoretically, on the most normal thing is that the temperature and CO2 goes down. And in fact, in this study of CISCA, that is very nice, that it was done in one city in the United States. And in the study, they compare the difference between the urban and the rural side. The difference in temperature, it was almost 2 degrees. So it was 2 degrees warmer in the city center. And the quantity of CO2, it was 1/5 more in the city center. So we have almost 2 degrees. In the urban side, it was 1/5 more, but it was transformed in 5 times more pollen. So that's why the allergenic pollen was much higher in the city center, and that is, together with the pollution, a real problem. Not only that, it was also described that 1 degree temperature in the north of Europe, where it's quite cold in the winter, has changed also the situation of the birch. And in fact, before, the birch was only in the very south of Finland, and now it's arriving to the middle area of Finland. Another important thing is new allergens that came. Well, many years ago in Europe, we were saying that the ragweed was a typical American problem because we were not having ragweed in Europe, and nowadays is also affecting most parts of Europe. In fact, this is an example. In Poland in the 2000, there were not a single count of ragweed, and just in 2 years, they were counting 100 grains of pollen per cubic meter. So it was a really increase. Another important are all these changes that we have in the temperature, and also the thunderstorms and the allergic respiratory disease, where we have these strong winds, and also together with these floodings and these dry periods, and it's terrible. The fact regarding the thunderstorms is very important that in that moment, people that is allergic to some grains, and that these grains may suffer an osmotic shock that actually release some areas of the pollen that are very, very aggressive and induce really some kind of bronchoconstriction. So those patients have to be careful to stay at home until all the pollen is really goes down due to the heavy rain. But at the beginning, when it's not raining so strong, it's really almost not raining, these changes may create problems. In fact, the subjects affected by pollen allergy should be alert at the danger of being outdoors during the thunderstorm in the pollen season. And another important pollutants are also the sunstorms. Like you can see here, this sun, how it's coming in Riyadh, in the capital of Saudi Arabia. And what happens in this moment, small particles can remain airborne for days, and they are transported hundreds of miles. And actually, these particles create really a lot of problems. And it's suddenly to the whole population, so all the hospitals suddenly become very collapsed. So that's why it's very important that we are now developing this study. This study is now in this moment is submitted, and we have tried to check how we can help the patients that are exposed to the allergens, that are exposed to the pollutants, and what we can use, how we can use also some personal data, like, and that's why we organized this real-world digital study, that it was evaluating the association between the levels of allergens, the pollutants, and also how with some of the symptoms, like is the Fitbit wearable system. And actually, almost 1,600 adult patients living in the US who experience moderate severe seasonal perennial allergic rhinitis. They complete twice daily allergen questionnaire for 16 weeks. It was happening during the spring 2020. And so the real-time air quality data and pollen counts were also collected, and everything was controlled: the total nasal symptom score, the pollen index, the CO, the NO2, the ozone, the particulate matter, and the activity tracking. And with all this data, the regression models was the association between the allergic rhinitis symptoms and the data that the personal data that that we obtain from the wearable and the pollutant levels. And this large study confirmed that there is the importance of the allergen plus the pollution is associated with increment of the allergic rhinitis symptoms. And also it was shown that the association and the use of these kind of personal devices will help to really monitor and probably that is the main goal, to predict before it happens that how the patients may have symptoms or not. Well, this is the study that is has been really finalized now, is just submitted, and we hope that in the future we can express much more about this DS up to study. But one thing that we were just doing together with the World Allergy Organization, and actually this was also in collaboration with Sanofi, we did the international expert consensus of the management of allergic rhinitis aggravated by air pollutants, because it was very important that the therapy, it has not to be only pharmacological. The therapy also for our patients should be environmental based. So we have to talk with the patients, to talk about education, to increase awareness, to abate the risk factors. So we need to spend time with the patients. So of course we will give the pharmacological treatment, saline dosing, non-sedating oral second generation modern antihistamines, intranasal corticosteroids, but we need to give recommendations to our patients, but not only regarding allergens, also regarding other triggers that may increase the allergic rhinitis and many other allergic symptoms. So this is very important. So we could say that the prevalence of allergic disease is increasing, allergies increasing worldwide. The climate change and the pollution are major contributors to this increment. So that's why the therapy should be environment-based, pharmacological, and education of the patients is very, very necessary. Thank you very much for your attention. It has been a pleasure to be here with you today.
Thank you for the excellent discussion of exposure to allergens and the effects of weather and pollution on the exposure to allergens. Dr. Anstey, first of all, to everyone, there's an opportunity. We can take one or two questions right now. And if you have a question, please type that into the question box. And secondly, at the end of the first section, of the end of the allergic rhinitis section, we can have a couple of more questions. Dr. Anzatighi, I do have, there's a question regarding, you very nicely showed the effect of exposure to allergens, the effect of pollution, and the effect of diet. And particularly in light of the Fitbit study, is there any evidence regarding exercise and reaction to allergens?
Well, in this study, they have been considered specific topics. We have not analyzed at the moment, because this is just the first paper. We are now developing the application and just to combine all the things. But in that moment, we are at the moment, we only have data regarding when they do activity, they also are outside the place where they are usually resting, because we know that they are outside. And so we are just now combining all these details. But these are very preliminary data, and probably in the future, we will also have even data regarding how was the diet of the patients. But at the moment, that is not included.
There's a follow-on question regarding the effect of infections and particularly in children, infections and the results of the response to allergens, pollution, and diet and weather.
Well, of course, we know that the infection are an enhancer of all the symptoms, and that is something that we always know. But in some relation for if the allergy is increasing due to the infections, we cannot say that. But we can say that, of course, the infections enhance many of the allergic symptoms.
Well, if I may intervene, Brian, with that.
I apologize. I thought there was somebody who tried to break in, and Dr. Raudi.
Okay, actually, in response to what Ignacio has just answered, and as an extension to what he stated, we don't have any epidemiological studies that would look at the impact of pollution on allergies, which is aggravated by infection. But what we do have are many in vitro studies that would demonstrate that pollution does affect allergies in a more severe way whenever the cells are exposed in vitro to an infectious insult. And we know that this affects primarily the innate immune system and subsequently the adaptive immune system. But the real mechanistic pathways are not fully clarified yet.
Thank you for that, Dr. Raudi. Our next speaker will be Dr. Nelson Rosario from Brazil. And Dr. Rosario will talk to us about the management of allergic rhinitis in adults and children. And I will again remind you that we can either ask questions directly after Dr. Rosario's talk, or we'll have a few minutes at the end of the allergic rhinitis section. Thank you.
Could you share the screen?
Yes.
Okay. First of all, thank you very much, Brian, for the introduction. And I'm really glad to participate in this webinar, really an international webinar. In my conflicts of interest. In the outline of this presentation, I'm going to show some similarities and differences between allergic rhinitis in children and adults, the consensus that are currently being used, the role of antihistamine in treating allergic rhinitis, the concept of minimal persistent inflammation, pollution and rhinitis, and finally, I'm gonna just touch on the exposure study. So this is the question. Are there clinical differences of allergic rhinitis with age? Is a young child or an old man having the different clinical manifestation? And how about treatment? Should we treat them differently? So this is a really question, because when we compare symptoms of rhinitis in adults and children, I'm sorry, this cartoon is in Portuguese, and I'm sure you are very familiar with Portuguese, but it's not difficult to understand that the nasal congestion is the main symptom of both in adults and children. What is difference is that children may cough more often than adults when they have allergic rhinitis. Another difference could be in the prevalence of headaches in adults and children. What is shown in this cartoon is 29% of the adult females, they experience headaches every day or most days a week, compared with only 18% of adult men and approximately 10% of children. So adults may complain more of headaches than children. This international survey of allergic rhinitis is an international multi-center cross-sectional study about management in real-life settings, and involved almost 3,000 patients in different countries, both adults and children over 6 years of age. And what is shown here is that the chief complaint of the diagnosis of allergic rhinitis was nasal congestion. Most of the people were complaining of nasal congestion, of sneezing, rhinorrhea, and itching were also common in patients with allergic rhinitis in this survey. So for the treatment, first, I question if the diagnosis is confirmed. Am I treating a patient with allergic rhinitis or a different form of rhinitis? Then which symptom affects mostly the patient? And what is the frequency and severity of symptoms? Frequency means that if it is real frequent symptoms, we have to give patients frequent medication. If it is sporadic, he's going to use as needed a medication. And severity of symptoms, it says to me, how much should I give the patient? Should I go to nasal corticosteroids or antihistamine is enough? When we perform an anterior rhinoscopy in a patient with allergic rhinitis, this is what we see: an edematous inferior turbinate, a pale bluish mucosa, and a clear rhinorrhea. What we expect from the treatment is a complete reversion of this fact. And if we go to this first consensus, this is the area allergic rhinitis and its impact on asthma, first published in the 2001. This is an update of 2008, and this is a schemes of different guidelines that, like international consensus on rhinitis, a North American Joint Task Force on Practice Parameters, the YACI consensus, the area 2001, and then the 2008. What we have here is antihistamines, first generation, should not be prescribed for patients with allergic rhinitis, and of course it should only be prescribed as first-line treatment for patients with mild forms of diseases. So this is the recommendation of area, and this is a recommendation, a practice parameter from the American Academy of Allergy in classifying treatments in patients with allergic rhinitis: first, non-sedating H1 antihistamine, orally, intranasally, also leukotriene receptor antagonists could be an option of treatment, or chromones, intranasal or intraocular. Second line, especially for patients with increasing symptoms or not controlling only with antihistamine, intranasal corticosteroids. And if a patient does not respond to intranasal corticosteroid, the combination of intranasal steroid with intranasal vasopressin could be the option. Oral steroids as a short course could be used as an add-on treatment. And we should consider referral to specialists for allergen immunotherapy if the patient is not going well under this treatment. The practice parameter recommend against prescribing a first-generation antihistamine and are in favor of second-generation antihistamine when prescribing oral treatment for allergic rhinitis, especially as initial treatment for patients with seasonal allergic rhinitis, being topically used the antihistamines or orally, especially patients with intermittent symptoms. Also, when choosing monotherapy for persistent allergic rhinitis, intranasal corticosteroids should be the preferred medication to be prescribed. Second generation antihistamine may have some sedation effect. This is a comparison of different antihistamines, as is shown here. As cetirizine is one of the second generation that is most probably causing sedation in patients on use of antihistamine, and fexofenadine would be the less sedative antihistamine. Fexofenadine did not cause sedation in adults receiving 11 times the recommended dose, like almost 1,400 milligrams, and did not cause sedation in this patient. This is a systematic review of the efficacy of fexofenadine in patients with seasonal allergic rhinitis. This is the first meta-analysis of randomized clinical trials on efficacy and safety of fexofenadine in allergic rhinitis. A large number of patients using the medication, the active medication versus placebo. There was not significant heterogeneity between studies. And it's shown that the frequency of the adverse events was similar between fexofenadine and placebo. This cartoon is a box plot showing 12-hour reflective symptom score, or 24-hour reflecting symptom score, showing that fexofenadine is superior than placebo, and individually symptom score like sneezing, rhinorrhea, nasal congestion, nasal itching, they were all benefited with the fexofenadine as compared to placebo. Even nasal congestion in this meta-analysis, as I said, adverse events were similar in both groups. Ignacio touched on the pathogenesis of the allergic reaction. There is an early phase response when a patient is exposed to an antigen, and there is a late phase response. This is an immediate one that occurs in the minutes after the exposure to the allergen, and chemical mediators are responsible for the symptoms and that we see in patients with rhinitis. Histamine is one of the main chemical mediators in this reaction. And the late phase response is an inflammatory reaction. Cells are attracted to this site through chemoattractants. One of them is molecular adhesion, the ICAM1, attracting cells, especially eosinophils, for this reaction. And this brings the concept of minimal persistent inflammation. ICAM1 is expressed on nasal epithelial cells in patients with acute rhinoconjunctivitis caused by either pollen or mite exposure, promoting migration of inflammatory cells and causing the inflammation. Even patients who are symptom-free may demonstrate the expression of this intercellular adhesion molecule 1. And nasal non-specific hyperreactivity is also a clinical feature, like was shown in patients with asthma. They have bronchial hyperreactivity, and patients with allergic rhinitis, they have a non-specific hyperreactivity, nasal symptoms when they are exposed to, say, changes in temperature, or if they are exposed to any kind of dust or odors, perfumes, and so on. And the prevalences of nasal hyperreactivity was detected in patients allergic and as well as patients non-allergic. This is a cartoon showing the minimal persistent inflammation. These are symptoms, and this is information showing that even when they are not having symptoms, they have some evidence of minimal persistent inflammation. And what are the clinical implications of this MPI? That even though second generation antihistamines are less effective on inflammation than they are on symptoms, it is recommended to continue the treatment of patients even when they are asymptomatic for some time. The duration and cessation of treatment, they have to be established. And the issue of compliance in the absence of symptoms also has to be considered, and safety for long-term use of the medication. But long-term studies in volunteers have demonstrated that fexofenadine is safe and well tolerated in doses up to 240 milligrams a day. Allergic rhinitis and pollution they are intimately associated. We know that pollution may increase the prevalence of allergic rhinitis and aggravate symptoms when patients are exposed. Diesel exhaust particles are a real life problem in patients with allergic rhinitis, and pollution may increase this nasal hyperreactivity in patients with an ongoing mucosal inflammation due to allergies. As Ignacio pointed, we have external pollutants and we have internal pollutants. This is a lady in Guatemala working in a three-stone fire, and the amount of PM2.5 are extremely high when they are cooking in home. There is association between pollutants and the level of severity of rhinitis. This is a multi-center European study of 1,400 adults. They were divided without allergic sensitization and with allergic sensitization. What is shown here, the particulate matter, when they are exposed to higher levels of pollution, they have more severe nasal symptoms, as demonstrated in these studies. We had a chance to look at air pollutants in Latin America recently. This is a systematic review of 12 papers, selected papers in different countries. And what is shown in this estimated model is that the patients exposed to pollutants, they have 36% more chance of experiencing allergic rhinitis. So this is a worldwide problem, not only in Europe or North America, but also in Latin America. We have a problem. Ignacio went to this study. This is the exposure study, and this is the schematic design. He has shown that patients were exposed to ragweed plus diesel exhaust particles. And finally, they were divided in two arms. One received fexofenadine and the other received placebo. Hours just before exposed to ragweed and the pollutants. These are the demographics of patients showing they were comparable in all respect. They had seasonal allergies due to ragweed. This is showing that exposing to pollen plus pollutant increases the allergic rhinitis symptoms. And when they are treated with fexofenadine, there is a reduction in total nasal symptom score in people exposed to allergen and to a pollutant. I want just to emphasize that not only nasal symptoms were controlled, but also ocular symptoms due to pollen and increased with the exposure to DIP. And the conclusion is fexofenadine is effective, well tolerated, and has been shown to alleviate pollution aggravated symptoms. Air pollution is a major risk factor contributing to morbidity and mortality from major chronic diseases. Children are vulnerable, especially due to their biological immaturity. Poor air quality is related to increased prevalence of clinical manifestations of both allergic rhinitis and asthma. And fexofenadine is the only medication that has been tested in a controlled allergen exposure facility to alleviate allergic rhinitis symptoms during a pollutant and allergen co-exposure. So this is the big burden of allergic rhinitis. It's like a patient with allergic rhinitis feel. Rhinitis is prevalent, impacts quality of life, nasal congestion is common, pollution aggravates allergic rhinitis, and there is a persistent inflammation. Fexofenadine is safe and effective in relieving allergic rhinitis in both children and adults. With this, I end my presentation and thank you for your attention. And I go back to you, Brian.
Dr. Rosario, thank you so much for that talk. There is a question in regards to during the pandemic, how do you advise patients in regards to avoiding allergens with indoor pollution as we're asking to spend more and more time indoors?
Yeah, this is a real challenge, and this is an action that we go for. We have to advise our patients that there is an increase of symptoms when they are exposed to pollutants during the pollen season. And staying indoors, it means that patients will not be exposed to many pollens, but they may be exposed to indoor pollutants. And the one that we advise that is real problem is tobacco smoke at home. So if I would take one pollutant, indoor pollutant, I would say, please do not smoke at home and avoid symptoms.
Mark.
Doctor.
I apologize. I was on mute and trying to ask a question. There's a second question regarding intranasal corticosteroids and how long we can use them, particularly in children.
Formulations are approved to be used in children after 2 years of age. Usually, I recommend to use 1 month, even if the symptoms are well controlled with medication. As I mentioned, there is a persistent inflammation in patients with allergic rhinitis, especially in here in our region, where mites are a problem because we are exposed constantly to this allergen, even in small amounts. So inflammation is persistent. We should maintain the medication for at least 4 weeks in order to control symptoms and inflammation.
Excuse me, Dr. Martin, we can actually elaborate more on this 2 important questions that Nelson has beautifully answered. If we have time, we can extrapolate on those at the end of the session, or we can do this right now.
Actually, Dr. Raoudi is correct. We do have, I want to keep the webinar on time. What we'll do now is move to our third talk, and we'll have Dr. Raoudi speak to us about allergic rhinitis management during the COVID-19 pandemic. I encourage everyone to continue to send questions to me, and we can ask those questions then at the end of the allergic rhinitis portion of this webinar. Thank you.
Hello, and thank you for joining me on this presentation on allergic diseases and their management during COVID-19. Well, we all agree that COVID-19 has been a unique and unparalleled experience for us. On one hand, it had a bad social impact because of limited mobility and lockdown. It had also terrible economic, global-wide repercussions. But on the other hand, we had the chance for the first time in human history to examine how our attitude and behavior can impact not only infection, but also allergies and pollution. This came out of Turkey, and it looked at the level of ambient air pollutants like particulate matter, ozone, nitric oxide, sulfur oxide, and carbon monoxide, and it measures and compares the level of those air pollutants between March to May in 2019 to the same period in 2020. And as you can see on the slide, there's a significant decrease in the level of these air pollutants. Now, we do expect this to reflect positively on inflammatory airway diseases. We know that air pollution increases airway hypersensitivity in patients with allergic diseases, and we have reported on this. The action happens at the airway mucosal barrier, and air pollution interferes with the innate immunity and the adaptive immunity, and we expect that with the lockdown, these parameters are going to improve. This came out of Korea in a huge study population, more than 92,000 people, and they have looked at the lockdown effect on the incidence of allergic rhinitis and asthma. And as you can see, the newly diagnosed cases of allergic rhinitis and asthma in 2020 dropped significantly compared to 2019. This is from Italy on patients who have seasonal allergic rhinitis, and they examined the medication used in the year 2020 compared to 2019. And you can see also that there's a significant decrease in consumption and prescription of anti-allergic medications such as systemic antihistamines, topical corticosteroids, and nasal decongestion. And this is from the same report looking at the SNOT-22 quality of life questionnaires and comparing them between the year 2019 and 2020. And as you can see, there's a significant improvement in the score of SNOT-22 in allergic rhinitis patients in 2020 compared to 2019. I would like also to highlight that more allergic rhinitis patients in 2020 felt less frustrated, less irritable, and less sad compared to 2019. Now, we are all primary care physicians or specialists, and we're still seeing patients with rhinitis. So the question becomes, is this COVID-19 or allergic rhinitis? And this shows the classification of rhinitis into 4 categories. Of course, we have the infectious rhinitis, including common cold, COVID-19, and the rhinosinusitis syndromes, such as acute viral and acute bacterial rhinosinusitis, the IgE-mediated inflammation, most notably allergic rhinitis, local allergic rhinitis, the non-IgE-mediated inflammation, such as NARIS, and the non-inflammatory or neurogenic rhinitis, which is marked by nasal hyperactivity. Most importantly is idiopathic or vasomotor rhinitis. Now, I am showing this because irrespective of the etiology of rhinitis that you have seen in the previous slide, or the ones which are marked on your left side of the slide, irrespective of the etiology, the nose can express only limited number of symptoms. So the nose can either block, it can get runny, it can sneeze, it can itch, it can have a decreased sense of smell, and of course you get headaches in those cases of rhinosinusitis, and low-grade fever really distinguishes infectious rhinitis from the other rhinitis phenotypes. And I want to include or to discuss a little bit the decreases of sense of smell, because as we know, this is huge in COVID-19. We know that the prevalence of olfactory dysfunction is much higher in COVID-19 as opposed to the general population. So an olfactory dysfunction is a disease pointer in COVID-19, especially if it was associated with a taste dysfunction. And we have reviewed that and looked at the way we do report olfactory dysfunction, whether this is objectively using smell test or whether this is subjectively. And we have really to be careful, because the subjective reporting of olfactory dysfunction really underestimates the true prevalence of olfactory dysfunction when it is reported using objective measures. Now, this is out of Italy, looking at 22 patients with allergic rhinoconjunctivitis who are in the onset of their COVID-19 infection. And what they have done, they have filled a mini rhinitis quality of life questionnaire at the onset of COVID-19 that you can see in orange. And they have asked them also to refill another rhinitis quality of life questionnaire on allergic rhinitis based on their recall of their last episode of allergic rhinitis. And you can clearly see that the patient can distinguish between those two entities. So the quality of life questionnaire really differs significantly between both diseases, and it doesn't take much of clinical judgment for us to distinguish also between those. This is another report from Italy. What they have done, they have asked 43 patients with COVID-19 to fill a SNOT-22 quality of life questionnaire, and they matched them with the 50 patients of allergic rhinitis who also filled SNOT-22. And I would like to highlight also that patients with allergic rhinitis scored less in terms of sadness and feeling of shame than those with COVID-19. And if you compare both SNOT-22, you're going to see also that there is a difference between COVID-19 and allergic rhinitis in terms of SNOT-22 scores. This is from a Euphoria paper, and what they have highlighted is that there are some symptoms which overlap between seasonal allergic rhinoconjunctivitis and COVID-19. Notably, they both share nasal blockage, rhinorrhea, and sneezing, although I would think sneezing is much more important in seasonal allergic rhinoconjunctivitis. Now, itching and conjunctivitis on the left is more prominent in seasonal allergic rhinitis, whereas we're all familiar with the COVID-19 remarkable symptoms of fever, malaise, myalgia, anosmia, or maybe olfactory dysfunction, dry cough, diarrhea, and to that I would probably add taste dysfunction. The management of allergic rhinitis during COVID-19 is quite challenging. Now, all guidelines agree that patients who have mild allergic rhinitis can be managed at home. You can do phone calls, you can do even audiovisual teleconferencing and advise those allergic rhinitis patients. And this practice of medicine remotely is by definition telemedicine. And what I would like to highlight more is the recent application of telemedicine, which is mobile health or the use of digital health application for the management of allergic rhinitis. So we know that there are more than 72 digital applications for allergic rhinitis in the market, and there are several hundreds of those for asthma. But the one I like more is really the Mask Air digital application. This came out from Area, and it is easily and freely downloadable on iOS and Android mobile phone. We have launched this recently in Arabia, and it's giving us beautiful results. So I wanted to share this with you. Now, I apologize, this is in Arabic. This is the main menu that you get when you click on the double click on the icon, and from that you get to answer 4 questions. It takes you 12 seconds to do that, and this system uses a VAS scoring system. With the tip of your finger, you can scroll the dot to the right, noting the most bothersome symptoms, or to the left, noting not bothersome at all. So it gives you, it asks you over all allergy symptoms, how do you feel on that with the VAS? And then there's another quick question for rhinitis, another question for conjunctivitis, and then there is one for asthma. Now, what you could do with that is the system places you in one of 3 areas. The orange, the green zone means that you are well controlled. The one in the middle means you're partially controlled, and the one up means you're poorly controlled. And if it happens that you score 3 VAS on 3 different consecutive days, then the system tells you that there's something wrong and you should check your physician with that. And then if you flip your phone, you get a calendar of your symptoms, and it shows you all those domains that you have been asked to fill. It tells you about, your work, your asthma, your conjunctivitis, rhinitis, and overall. This is a beautifully manageable during the COVID-19 pandemic and during lockdown, because you can share this directly with your healthcare professional, and based on that, your physician can prescribe you medications or modify the one that you are previously on. Now, the management of allergic rhinitis during COVID-19 is quite challenging. So as we said, for those patients who have moderate or severe allergic rhinitis and get to visit the hospital, then it is our job to make sure that those patients do not have COVID-19 symptoms. And you go over the symptoms that you see on the left, most importantly, the epidemiological history. And we have also to dig in their history, just make sure that they haven't traveled recently to a place where there's a high prevalence of COVID-19. They have not been in contact or with a patient with COVID-19. Now, based on these symptoms, you might decide to transfer your patient to the fever clinic, and you can do all those COVID-19 testing protocols. If you decide that that patient can be referred to the allergy clinic, then we have to make sure that we withhold all those type of treatments, such as skin prick testing, skin endpoint titration, RAS testing, and others like endoscopy. I'm going to talk about pharmacotherapy and immunotherapy in a second, but I want to highlight also the social distancing that we should implement in our clinic and the personal safety measures. The literature is very rich in those precautions. This is from a Yaki area position paper, and it describes how you should behave and your patient and your nurse in the office. But this one drew my attention. This is on the use of face mask in patients with allergic rhinitis. What they did, they took all those nurses complaining of chronic rhinitis, and those nurses were tested using regular surgical mask, N92, N95 face mask, and what they have noticed is that these face masks did really decrease the symptom severity. So these masks do not only have a protective role for COVID-19, but also they can actually decrease the severity of your allergic rhinitis symptoms. Now, for asthma, these have been well described. You use GINA guidelines for anti-asthma therapy, should reduce systemic steroids, use metered dose inhalers or powder inhalers, not nebulizers. Now, spirometry, it is a general agreement that it should be stopped or withheld, and in Asia, for example, only if this is a treatment changer, then you can do spirometry. In Asia, immunotherapy, subcutaneous immunotherapy is deferred. If you're talking about maintenance dose, you have to individualize, but with respect to sublingual immunotherapy, there is no interruption. And you're going to see later on that this can differ in different parts of the world. Now, biologics also have been into question. WOW has issued a consensus describing the use of biologics during COVID-19, and it describes all those drawbacks or disadvantages of stopping biologics. This is also important in the upper airway because many patients who have chronic rhinosinusitis with nasal polyps, with or without asthma, are also on biological therapy. And our position has been to continue biological therapy in patients where they are clearly indicated. Now, with the rest of the time, I'm going to go over two clinical cases because things in real life might be different from what you read. And the first case is a 32-year-old health male. This is a patient who has seasonal allergic rhinitis. He has also asthma with it. He has been on good control. He has been on sublingual also immunotherapy, but he stopped it because of, as he claims, COVID-19. Since then, he has been on daily intranasal steroids and occasionally on SABAs. Now, that patient presented to the emergency room with acute episode of seasonal allergic rhinitis because he was in the season, during the season, and after examining him, he had some queries. The first question he asked, does allergic rhinitis or asthma going to predispose me to COVID-19 or its complications? And his queries also were, what should I do with my intranasal steroids, inhalers, and my immunotherapy? So these are legitimate questions. And with respect to the first question, we know that SARS-CoV-2 uses the ACE2 receptor, which is present on the mucosal cells. And for it to fuse with the cell, we need activation of the serine protease to activate the S protein for the fusion to occur. Now, we think that ACE2 receptor is an interferon gamma stimulated gene. So ultimately, diseases which increase or overexpress interferon gamma, such as bacterial tonsillitis, for example, are going to predispose more for COVID-19, whereas diseases which downregulate interferon gamma, such as type 2 inflammatory diseases, of which are allergic rhinitis and type 2 asthma, we think that these are going to protect from COVID-19. Now, remember that these are not quantitated, but it seems logical to assume that. So, does allergic rhinitis predispose our patient to COVID-19 complications? This is a series out of Turkey, 125 patients who had COVID-19 and were hospitalized for that. They went retrospectively and looked at those who have or do not have allergic rhinitis, and they looked back at their length of hospital stay. And as you can see, those who had allergic rhinitis did not really differ from those who did not have allergic rhinitis in terms of length of hospitalization. So it seems that having allergic rhinitis does not predispose to more COVID-19 complications. Now, should the patient stop his intranasal steroids? Well, this is another one from also Turkey, looking at COVID-19 patients who have had full recovery from that. The total number of patients were 47, 16 of which were on chronic use of intranasal steroids for more than 16 months, and they have asked both the control and the INS group to record a SNOT-22 quality of life questionnaire, and they looked at their recovery time of olfactory dysfunction and taste dysfunction. And what turned out to be is that those who were on more than 6 months of intranasal steroid scored better on their SNOT-22, and also they had a shorter recovery time of olfactory and taste dysfunction. So based on this epidemiological study, it seems that chronic intranasal steroids improves SNOT-22 and shortens recovery in COVID-19 patients. This is from Area Iyaki statement using the Delphi method. What we have done with that is that we have sent those questionnaires to many KOL across the globe, and using, as I said, the Delphi method, the majority agreed that the intranasal steroid should be continued during the hay fever season, and the suppression of the immune system does not occur with INS. And actually, if you stop the INS, you're going to trigger more sneezing, which contributes more to spreading of coronavirus. What also Iyaki and Area has done is that they have distinguished two types of COVID-19 patients with respect to the question of immunotherapy. Now, for patients who are diagnosed COVID-19 cases or suspected of having COVID-19, we should stop all types of immunotherapy, whether sublingual or subcutaneous. Whereas those who are non-infected or who have recovered from COVID-19, we should continue immunotherapy with that. But it does not really say what's the standpoint with respect to initiation and escalation. And I think these relate mainly to those who are on maintenance treatment. Now, this is another report looking at immunotherapy from a different angle. We should really distinguish what's the current COVID-19 status. Are we in the pandemic with a high community prevalence? Have we surpassed the peak? We are in low community prevalence, or we are post-pandemic and COVID-19 is controlled. And in those patients, and when COVID-19 is in the red zone, the recommendation has been to stop initiating or escalating the doses of immunotherapy, whereas those who are on maintenance should continue. So as you can see, there are many different recommendations in different parts of the world. So going back to our patients, it is unlikely that allergic rhinitis or asthma predisposed to COVID-19 or the complications. It is advisable not to stop intranasal steroids. And if the patient is advised immunotherapy, we should stop it till the resolution of COVID-19. My second case is rather a quick case. This is a 44-year-old male engineer. He's a case of obsessive compulsive disease. He's on antidepressants. And he has been on daily intranasal steroids, and he has not been compliant with lockdown, unrestricted activity. And he presented to the emergency room with acute tachypnea, difficulty in breathing. So obviously he was hyperventilating. His lung exam laboratory findings were all normal. So he was diagnosed with an acute anxiety attack. His psychiatrist was consulted also. So what the resident in charge did is that he advised him to continue intranasal steroids and to be on lockdown. And before he left, he actually, because I think he was obsessive, he actually asked the resident a interesting question. And it was like, since he has dust mite allergy, is lockdown going to affect his dust mite allergy? And this is a legitimate question, because we know that lockdown is going to decrease our non-specific airway hyperreactivity. It's going to improve the seasonal allergic rhinitis symptoms and the asthma symptoms and improve the medication. But now what we're doing is we're taking somebody who has dust mite allergy and we're putting him in lockdown, and we're asking him to really get exposed more to his indoor allergens. Now, this is an interesting, and it came from also Turkey, 165 patients who are known to be dust mite asthmatics. And what they have done is they have compared the asthma control test between the year 2019 and 2020. And they have distinguished two types of patients: those who are dust mite asthmatics and have allergic rhinitis, as you can see over here, and those who have not. And what they have noted is that the asthma control test has improved with lockdown, irrespective whether the patient has allergic rhinitis or not. But if you go a little bit into their findings, if you focus basically on patients who are dust mite asthmatics and you look at their rhinitis symptoms, you're going to find that nasal blockage has really worsened. And also the conjunctivitis symptoms have really worsened. So according to this report, the lockdown is going to worsen your allergic rhinitis symptoms. And this is in contradistinction to another one from Italy, where they have looked at 82 patients, pediatric children, and they have looked at their different phenotypes of allergies, whether they have allergic rhinitis alone or asthma alone, or whether they have multimorbidities. And if you focus on the rhinitis group, those who have allergic rhinitis, and you stratify them into three categories of whether they're purely allergic to dust mite, or they have multiple sensitization over here, or whether they're simply allergic to grasses, you can see that the majority of patients who have dust mite allergy have actually stayed the same or have improved, in contradistinction to the previous findings. And if you look also examine all those different sensitizations, you're going to find out that in the allergic rhinitis group, those who have improved most have been those who have grass pollen allergy, then polysensitized, then dust mite allergy. So really two conflicting results, and it's important to see that or to think of indoor allergens in lockdown. During lockdown, we are increasing exposure not only to indoor allergens, but pollutants. We know that this is going to improve asthma based on these epidemiological studies, but we're not sure about allergic rhinitis. So answering our patient is very simple. There is no clear data on this yet. So with that, I would like to conclude, and I apologize for taking a little bit more than the allotted time. The management guidelines differ in different geographical areas. They are clearly not evidence-based, but they rely on epidemiological studies which are really small-sized, and also they rely on expert consensus. But what we know so far is the lockdown does really improve allergic rhinitis and asthma symptoms, and I find digital health applications particularly useful during the pandemic. Of course, safety precautions need to be implemented, and to summarize all of that, we should really individualize the management of each patient and use our clinical judgment to the best in the management process. I want to thank you all for your attention and stay safe. Thank you.
Dr. Raoudi, thank you so much for that presentation. There are a number of questions that have been asked, and in the questions, a number of questions revolve around the utilization of our face masks and the number of patients who are staying indoors during the pandemic and the effect of both of those on allergens. I know that much of your talk looked at those, but specifically, what do you tell your patients when they ask questions about wearing the mask and what effect that's going to have on their allergies or their asthma?
Well, we have to say that the data is still inflowing, and we don't have clear evidence based on prospective studies on what would be our recommendations. So, as I said, we have to use clinical judgment in this. We rely heavily on retrospective epidemiological studies. And with that, I would say also that there are a lot of confounding variables. So clear recommendations, I think, are far from reach right now. So we really have to use common sense with that. And I would still recommend very strongly all people to use face masks, obviously, especially those who have allergic rhinitis. But the story becomes different when you talk about indoor allergens or outdoor allergens. Now, obviously, if you have seasonal allergic rhinitis and you go outdoor, the face mask is going to protect you. It makes sense, and we have epidemiological evidence, though this is retrospective, but we do have it that it is efficacious. Now, as I said, the problem is with people who have either polysensitization or mainly indoor allergens. And it is early to tell, but from what we have been reading in the literature, it seems that protection with the lockdown in asthmatic patients who are allergic to dust mite does work despite prolonged exposures, as if this insinuates that outdoor allergens or maybe outdoor ambient pollutants seem to be more important in those patients that we have studied. Now, we have to remember that the inclusion criteria in all those reports is not very stringent, and we have many confounding variables in that. So we cannot really generalize and say that asthmatic patients who are allergic to dust mite are always protected indoors. And the other, and the reverse is true. We cannot generalize and say that allergic rhinitis patients sensitized to dust mite actually are going to have worsening of their symptoms. We simply have no clear data so far, and we need prospective randomized studies to come up with recommendations concerning this. But so far, as in COVID, based on what we have, it is safe to say for now that face masks are protective for allergic rhinitis and for COVID-19 as well.
So I do want to keep us on time. I have one last question for the panel as a whole, and there have been several questions regarding the duration of use for therapy, either in using inhaled nasal corticosteroids or in using antihistamines. So what advice have you for length of therapy on either of these therapeutic agents?
Are we talking about safety or efficacy?
The question was asked really on just in terms of both safety and relief regarding the duration of use of either antihistamines or steroids, or inhaled nasal corticosteroids.
Okay, if I may answer first, safety of intranasal steroids can be computed in so many different ways, and there's so far I would say the CDC or the FDA has launched several recommendations concerning safety and how you measure safety. There are different ways of measuring safety of intranasal steroids. You can look histologically on the microscope and examine the mucosal epithelium, and all the studies on all commonly used intranasal steroids in the market have really shown that there is practically or non-significant changes in the mucosal epithelium. Now, you can do that also in the blood. You can measure serum cortisol levels, insinuating that intranasal steroids or inhaled steroids can interfere with the pituitary ACTH axis, with the pituitary adrenal axis. And there are tons of studies that prove that both of them do not really change either serum cortisol level or 24-hour urine collection for that. But really the most elegant ones are the ones that have been done over 1 year of continuous use. And with that, you're going to do what you call nemometry, basically measuring the diameter of the knee, or you're going to measure the length of the bone. We're talking about children, obviously. And this is a tedious work that has been done. And I would say there are a couple of intranasal steroids that turned out to decrease length of few centimeters per year. But then again, we have always to remember, and we have to criticize this scientifically, we don't know if there's going to be compensation inborn metabolism later on. Now, it makes sense because most of the people, a great percentage of people use intranasal steroids, and these are not shorter than the other people. So I would say it is based on what we have, it is safe to use that. And, I do have several, I would say, few hundreds of patients pediatric patients that I have put on nasal steroid continuously for 6 to 9 months. So as far as it concerns me, I think these are rather safe medications.
There's one more question that has come in there. There are a number of questions, but I fear we're running out of time. And I would like to end on the question that has come in regarding how we advise our patients in terms of the aggravation of indoor allergens when we have pandemic, and what we say to our patients, or please share your thoughts about how we advise our patients in regard to indoor allergens in an era when we spend more time indoors and there are quite a few indoor pollutants.
Well, I can contribute to that. When you have dust mite allergy or you have molds, allergy to molds, the best thing is to really use the regular precautions and the regular avoidance measures that I'm sure Nelson also has described. Using acari seeds. These are general recommendations for allergic rhinitis patients or allergic asthma patients to minimize exposure to indoor allergens. But also my concern would be indoor pollution, because now we are on lockdown and we are more and more exposed to a longer period of time to indoor pollutants. And these, we know they come from cooking, they come from all different appliances that you use inside homes. So we really have to maintain adequate ventilation throughout the lockdown to minimize exposure to those pollutants.
If I may, I would like also to add that actually the question can be also replied by the use of the international consensus. Doesn't matter if we are just talking about outdoor or indoor pollutants. In this case, we are talking about indoor pollutants. But what is the main question? The main question is that we have to sit down together with the patient and try not to analyze only the allergen exposure that the patient may have indoor. Also, if they are using, which are the cleaners that they are using, how they are cooking, as Philippe said, mentioned, how is the ventilation, how they have to clean without using so harmful products. So always, it's not that we only give the treatment, let's call medical treatment or pharmacological treatment. We also give environment-based treatment, and this is very important. And this is one of the major goals, actually, that we are just following in the WOW, just to enhance the activity of the doctor with the patient, not only to prescribe medicines, but prescribe medicines, of course, but together with good advice for having a better quality of life in our patients.
Thank you so much for the answers to the questions. Thanks to the audience for the questions that you have provided. This will conclude the first half of today's webinar on allergic rhinitis. And what I would like to do now is we'll take about a 5-minute break and then allow Dr. Ibasawa to take over for the second half of our webinar. Thank you to everyone, and we'll be back momentarily.
Thank you.
Thank you.
Thank you very much for joining today's webinar series by WHO. Second part is going to be Urticaria. My name is Motohiro Ebisawa from Japan, current president of WHO. I'm going to chair the second part of this session. And we have very distinguished three speakers from all over the world. The first talk is a better understanding of urticaria by Jonathan Bernstein from USA. Second one is management of urticaria in adults by George Walter Canonica from Italy. The final talk is management of urticaria in children, Sandra Nora Gonzalez Diaz from Mexico. And we're going to receive a specific question for each talks, and then if time is available, I'd like to have a total discussion at the last. So please enjoy, and also please raise a question to our talks, and thank you very much for your attention.
Hello, I'm Dr. Jonathan Bernstein, and I'm giving a webinar on new insights for optimal management of allergic diseases, focusing on a better understanding of urticaria. The objectives of this talk is to define a better understanding of urticaria and to describe management of urticaria in adults and children. Let's begin by discussing the classification of chronic urticaria. It is now referred to as chronic spontaneous urticaria, whereas previously we referred to it as chronic idiopathic urticaria. And it refers to the spontaneous appearance of wheals, angioedema, or both for 6 weeks or longer due to known or unknown causes. The previous terminology, chronic idiopathic urticaria, has been removed or changed largely because there are many underlying causes related to the pathomechanism of this condition, and it really doesn't describe the nature of the hives, the clinical nature of being spontaneous, chronic hives. Chronic inducible urticarias were previously termed physical urticaria, and these occur in about 30% of patients with chronic urticaria and are induced by a number of physical triggers, including scratching the skin, referred to as dermatographism, cold urticaria, which can be reproduced with an ice cube challenge or a test called the temp test. And there's many other physical triggers that can cause urticaria in subsets of patients, including pressure, emotions, sunlight, exercise, heat, vibration, and so on. Now, urticaria vasculitis is also something that must be considered when evaluating patients with chronic urticaria, but this occurs in less than 1% of all cases of urticaria. Now, chronic urticaria can occur in any individual, children through elderly individuals. The duration typically lasts anywhere from 3 to 10 years, and the most common presentation is between the ages of 20 and 40. The mean duration is typically 5 years. Now, patients who have CINDU, a chronic inducible urticaria component, tend to have more protracted and a severe course of disease. And you can see from this pictorial that about 40% of patients with urticaria have isolated hives and wheals, whereas 40% have urticaria and angioedema, and up to 20% might have isolated angioedema. Now, when we think of wheals, we have to understand what they are. These are edematous raised welts, areas that vary in size and shape and are surrounded by redness, as seen in this picture. They can be itchy, but sometimes patients complain of pain or burning sensation. And the wheals typically are evanescent, meaning they disappear between 30 minutes and 24 hours after onset. Now, angioedema, it refers to the sudden swelling of the lower dermis and subcutis, may be associated with erythema. You can see the picture of the individual on the left with a lower lip swelling. It commonly affects areas above the neck, like eyes, lips, tongue, but can also affect genitalia. This angioedema typically resolves within 72 hours after onset. Now, patients can present with systemic symptoms, including joint pain, fatigue, and/or shortness of breath. Now, when we look at the histology of a lesion, urticaria lesion, it's important to note that one would see a predominance of CD4 lymphocytes with mixtures of Th1, Th2 cells, very few CD8 cells, and many monocytes with some basophils. There's no evidence of necrotizing vasculitis. The vessel walls are intact, but there is perivascular infiltration. In addition to lymphocytes, there's a variable number of neutrophils and eosinophils. And it's been reported that patients with chronic autoimmune urticaria, which is more chronic than chronic spontaneous, more protracted than chronic spontaneous urticaria, typically has a histologic pattern with variable numbers of neutrophils and eosinophils, whereas the classical chronic uncomplicated urticaria, spontaneous urticaria, has lymphocytes with infiltrating eosinophils. Now, when we look at the histology, again, we see another picture here on the left of a dermal, which shows dermal edema and mild perivascular infiltrates of lymphocytes, eosinophils, and neutrophils. When we look at patients who have more neutrophils on their biopsies, we see that they're not as well controlled on medications, conventional medications such as antihistamines. When they have more lymphocytes, they tend to be better controlled with medications. And then, of course, patients can be poorly controlled or well controlled with the presence of eosinophils. So the biopsy has a lot of useful information in helping us understand the type of hives patients may be presenting with. Now, it's been known for quite some time that there is an association of autoimmunity and chronic spontaneous urticaria. And this is one large population study that looked at the prevalence of autoimmune diseases in patients before and after developing hives. And you can see that these patients, once they've been diagnosed with hives, have an increased frequency of these autoimmune diseases. Again, this is looking at the total population, and this is looking at females and males. Now, of course, females have more antibodies for certain subtypes of autoimmune disease because they are more prevalent in women than men. But in terms of the timing of diagnosis, you can see before the prevalence of these conditions is about 19% to 22%, but after diagnosis, the prevalence goes up quite high to 77% to up to 84% in some cases. And here you see that the serologic markers that are seen in these patients are elevated, which is consistent with these diagnoses. So autoimmunity is quite prevalent. Of course, this study had several limitations inherent in any large population survey. If authors comment that to evaluate whether or which autoimmune disease and serologic markers have the most important effect or relation to chronic urticaria, it would require more detailed information regarding the course of disease and close follow-up, which was not possible in the context of this type of study. Now, it's also been well reported that patients with chronic urticaria develop autoantibodies targeting high affinity Ig receptors referred to as Fc epsilon receptor 1, specifically the alpha subunit. And here you see an IgG anti-Ig antibody targeting the receptor. And this can occur up to 35 to 40% of patients. And in a smaller percentage of patients, they may make an Ig antibody to the alpha subunit of IgE itself, and not the receptor. And again, we can see this. One of the early tests that was used to make this diagnosis of autoimmune urticaria was an autologous serum skin test. Some individuals used a plasma test, which was thought to be more sensitive, but suffice it to say, one could see a wheal and flare when you inject a sample of the patient's own serum into their forearm in the context of a negative saline and positive histamine control. And this was evidence that there might be an antibody targeting the Ig receptors on mast cells. However, it's been subsequently found that many people who don't have hives also might have a positive autologous serum skin test. And this test has been largely supplanted by basophil activations assays. Now, what is the relevance of autoimmunity? And this is one study which showed that there are certain clinical laboratory characteristics of ANA positive chronic urticaria patients that differentiate them from patients without positive in ANA. And here they compared ANA positive patients with hives versus ANA negative patients with hives and ANA positive patients without hives. And they found that patients who had ANA positive and hives had higher prevalence of Sjogren antibodies, thyroid autoimmune disease, as well as elevated C-reactive proteins. They were more prone to being basopenic, and they had resistance to up to 4 times the dose of antihistamine. So it tells us that these patients are less responsive to antihistamines. Now, given the fact that this is a chronic disease and many times requires different types of medications, multiple physician visits to really control the hives, it's not surprising that chronic spontaneous urticaria is associated with a significant economic burden. This is one retrospective cross-sectional cohort study which used commercial health insurance claims databases. They looked at over 13 million individuals in every region of the U.S., and they looked at chronic urticaria identified by ICD-9 coding, and they identified 5,800 individuals who were continuously enrolled in 2012, and they found that the prevalence of this population is about 0.11%. About 6,350 of these individuals had chronic urticaria, which was twice as common in women compared to men, and up to 23.5% of patients actually also had associated angioedema. And a number of these patients, a significant percentage, were hospitalized, and even more were seen in the emergency department for chronic hives. And the age range was between 25 and 44, which has been previously reported. But what one can see is that the actual cost, the mean annual cost to manage chronic urticaria, approached that of hypertension and diabetes. So in general, chronic urticaria is a significant burdensome illness that creates has a significant economic impact on society. Now, it's also important when we look at the economics of hives, not just direct costs, but also indirect costs. When patients are asked, what's the worst aspect of your hives? They say, for the most part, the swellings, but also itching and pain and being tired, and not having control of their body, the unpredictability of attacks, social restrictions, feeling embarrassed, missing work, and side effects from the medications that they're taking. So they actually had significant complaints and that affected their quality of life. And this is why it's important to measure an individual's perception of the impact of an illness or its treatment on their life, and which should focus on questions related to physical well-being, emotional well-being, as well as satisfaction with social functioning. And there are now a number of patient-reported outcomes that are assessed by the individual patient and not their provider, which is very useful in giving a better understanding of how patients are dealing with this chronic illness. Guidelines encourage disease activity and impact and to be measured using validated tools such as Urticaria Activity Score, Angioedema Activity Score, the Chronic Urticaria Quality of Life, and Angioedema Quality of Life Forms, and the Urticaria Control Test. So what are these tests? Well, the quality of life measures have a recall of anywhere from 7 days to 4 weeks, depending on the instrument. The Chronic Urticaria Quality of Life, Angioedema Quality of Life, and the Dermatology Life Quality Index. These all actually measure very similar types of things. The CU quality of life measures the overall impact of itching and swelling, as well as its impact on life activity, sleep, limitations, and looks. And the Dermatology Life Questionnaire also looks at 6 domains: symptoms and feelings, daily activities, leisure, work, school, personal relationships, and treatment. So they measure different facets of chronic urticaria and can really help provide the clinician with where patients are at the baseline when they come in and how they feel once their urticaria is well controlled. So what is the diagnostic workup in urticaria? Well, first, it's important to see if it's chronic. Has it been going on longer than 6 weeks? And therefore, that would exclude acute urticaria. And so the other question is, do they have any inducible components that can make the hives worse? Heat, cold, exercise, pressure, sunlight. No, then you've excluded chronic inducible urticaria. And then, so once you've established that this is chronic spontaneous urticaria, it's important through the history to check for severe systemic inflammatory disease, and to measure using certain instruments, disease activity, quality of life impairment, as well as disease control. Now, these are examples of provocation tests that can capture or reproduce chronic inducible urticaria. And again, I won't go into this in great detail, but a number of these apparatuses have to be purchased, but there are makeshift ones. For instance, a temp test for urticaria is a box that you can purchase that will give accurate temperatures, but it may not be affordable for everyone. So you could use basically an ice cube in a plastic bag with water and affix that to the forearm for 5 to 10 minutes, and then see if there's a wheal and flare response. So there are other ways of eliciting these responses, but one should be familiar with the modalities that are used to measure chronic inducible hives. Now, the patient-reported outcome tools are summarized here. The urticaria activity score, which is a recall period of 24 hours, but it's administered daily for 7 days, and it rates the severity of itch as well as the number of hives. The angioedema activity score has a recall also of 24 hours, and that's also administered for 7 days and provides information on swelling episodes at the time, what time of day do they occur, the severity of physical discomfort from the swelling, impact of swelling on daily activities and appearance, and the overall severity of swelling. Now, the urticaria control test is basically very short, and it is a recall of 4 weeks, and it does ask patients to communicate regarding the extent of suffering from physical symptoms, the extent which their quality of life was affected by hives, how often treatment was not measured was not enough to control symptoms, and then what was their overall control of urticaria. So these are actually used in research settings to objectively assess patients with hives before and after treatment, but they're easy to utilize in the private setting as well or in your practice when you see patients with chronic urticaria. Here's how the chronic urticaria disease activity score, the UAS urticaria activity score, is rated. There's a 4-point scale, 0 being none and 3 being intense. And patients then are broken down to how many wheals they have on their body. If it's mild, they have less than 20 wheals per 24 hours. But if it's intense, they have over 50 wheals per 24 hours. And again, one can also classify or clinically characterize the degree of pruritus. Obviously, if it's present, but it may be present but not annoying or troublesome, whereas it may be severe and sufficiently troublesome to interfere with normal activity and sleep. So again, these are easy to use and provide a longitudinal assessment of how well patients are responding to treatment. So the next question to be asked is, should patients with chronic urticaria have extensive testing to identify an underlying cause? And again, both guidelines recommend a limited workup for chronic urticaria as the cause is seldom found. CBC with differential sedimentation rate, C-reactive protein, and elimination of potential underlying causes is recommended. Additional testing such as TSH and LFTs may be appropriate. There is latitude for additional testing if there is clinical suspicion for an underlying cause. It is not recommended to routinely screen for Helicobacter pylori, as it's not recommended by other guidelines because the evidence for this test is very low. And again, one should not perform skin testing to aero allergens in foods in patients with chronic urticaria because of the hives may confound the results. And if it is necessary, if patients do have allergic rhinitis or allergic asthma, you want to identify what they may or may not be sensitized to. One can do blood work in these patients. Now, this is a study by Cleveland Clinic, which showed that one reason why it's not good to just do road testing, they looked at the number of tests that were ordered in their patient population. You can see CBC, CMP, H. pylori, sed rate. All of these things were looked at, and out of all of these patients, 356 patients, only one with hypothyroidism and normal TSH and elevated microsomal antibody responded to a higher dose of thyroxine. But again, extensive testing beyond a limited number of tests throughout other underlying causes is recommended. Now, this is an interesting study that looked at clinical and laboratory characteristics in antihistamine responsive and non-responsive patients. And you can see antihistamine non-responsive patients have a higher frequency of angioedema, physical urticaria, an autologous serum skin test being positive, baseline visual analog urticaria activity scores, as well as basopenia. They have lower basophils compared to patients who are responsive. Their MP values are higher, their C-reactive proteins are higher, and their C3 levels are higher. So these are all clinical markers which would predict potentially the lack of response or poor response of patients with hives to certain therapies, such as antihistamines. Now, there's also emerging basophil degranulation phenotypes, and these are responders to anti-Ig stimulation where they release over 10% or greater histamine release compared to non-responders, and this refers to patients who are release less than 10% of histamine. These patients who were the basophil degranulation phenotype, they had longer duration of disease, higher frequency of ED admissions, higher itch severity, no difference in oral corticosteroids, work loss, or quality of life. So again, these subpopulations are starting to emerge. And on further investigation, we found that biomarkers can actually potentially predict drug treatment. And this was a study that looked at for patients who are on antihistamines, omalizumab and cyclosporin. They looked at patients who were treated clinically as well as molecularly and that were resistant, had a few biomarkers. They had some demographic characteristics and a high UAS7. Whereas patients also who were unresponsive to antihistamines also had high C5a, IL-6 D dimers, and a positive ASST. And in contrast, patients who are on omalizumab, their molecular risk factors include basophil histamine release, autologous serum skin test, low IgE levels, as well as expression of CD203C upregulation on basophils. And then you can go down and you can see that there's also characteristics of patients who don't respond to drug treatment. And then you can see there's various reasons for that. Patients with negative basophil histamine releasing assay, negative autologous serum skin test, lack of CD203C basophils, high Ig levels, and high Fc epsilon receptor 1 levels will be more likely to respond favorably to omalizumab. So we're now at the point where we can order certain tests and we can help predict response to treatment. So what test should be ordered? Well, in the initial assessment, certainly a CBC with differential to assess for both basopenia and eosinopenia, both of which have been associated with worsening disease or more severe disease. A sed rate, C-reactive protein, TSH, and a D dimer. Some of these tests, such as CRP and D dimer, are also predictors of poor response to antihistamines. Now, if patients are not responsive to maximum step 2 therapy, one should look at a total Ig, a thyroid peroxidase antibody chronic urticaria index, as well as consider skin biopsy to make sure there's no evidence of vasculitis or other confounding factors. So this is the step care management of patients with chronic urticaria, contrasting the international guidelines on the left and the US guidelines on the right. And you can see that there is consensus with monotherapy with second generation antihistamines as first line therapy. But when you get to second line, there's both recommend updosing to 4 times the recommended dose. But the US guidelines also advocate possibly adding another second generation antihistamine, an H2 antagonist, a leukotriene receptor antagonist, or even a first generation antihistamine. But this is where there was some significant discordance between the guidelines, and also recognize that these came out in 2014 and the international guidelines were released in 2018, and there's a new version that's currently in press. But I think what's important to mention that the step 1 of the algorithm, all of the organizations endorse a second generation antihistamine as a first line therapy. And the reason for that is because these agents are efficacious in numerous published randomized controlled trials since the 1950s, and they are associated with risk for sedation, whereas first generation antihistamines are associated with risk for sedation and anticholinergic effects. Second generation antihistamines are not, so they're better tolerated. So there's a strong recommendation for antihistamines. However, when you go further down that or up that algorithm, you see that there's may not be as obvious, and the recommendations may not always coincide with what treatments to use, and that's why we need more objective evidence to really select treatment recommendations. And this is what the GRADE approach tries to do. It really tries to separate between quality of evidence and strength of recommendation. It provides the ability to downgrade or upgrade evidence based on methodologic criteria. It provides consideration of the relative importance of various outcomes to patients, and assesses values and preferences in association with making recommendations. And they then make, once they have a clear understanding of the implications, they make recommendations based on being strong or weak recommendations. So this is a pictorial which shows how this process works. One starts with a PICO question, which is what is the problem, what is the intervention, what is the comparator, and what's the outcome. And you can see that as they go through this rigorous analysis of the literature, they also have to randomize these studies based on initial quality. What types of limitations do they have? Do they have risk of bias, or is it inconsistent data? And then what about the effects of other co-founder drugs and so forth? So I think it's important now that we screen patients with the tests that we know would make them less responsive to this particular therapy. And we therefore make recommendations based on being strong recommendations versus suggest, and I think that's helps the reader to understand the quality of evidence when it's placed in this context. So what is the justification for high-dose H1 antihistamines? And this was a study where patients were randomized to receive either desloratadine or levocetirizine, and they went through several updosing stages after each week until they got to the maximum dose of 20 milligrams. And then they would switch. If they weren't controlled, they would switch to the other group and receive the drug desloratadine if they were receiving levocetirizine, and the desloratadine would be taking the levocetirizine. And from this figure on the right, you can see that there was continued improvement when patients switched from desloratadine to the levocetirizine. And again, this is providing justification because these patients were on high-dose antihistamines and they had no side effects. It was a safe study. So this is one type of study that would support that 4 times the recommended dose. Now, again, you see the comparison between the U.S. guidelines and the international guidelines, and you see that there are certain recommendations that once patients are up dosed to 4 times the recommended dose, they might also receive an H2 antagonist or a leukotriene receptor antagonist. And of course, it hasn't been shown that these agents have definitive benefits in chronic urticaria, and therefore the international guidelines said we could not make a recommendation respective montelukast as add-on treatment to H1 antihistamines in patients with chronic urticaria who are unresponsive to H1 antihistamines. And whereas in the Joint Task Force U.S. guidelines, they acknowledge that there were several relatively small controlled studies that indicate its efficacy, but given the benign side effects of this agent and their general tolerability, they were considered in CU patients who had unsatisfactory responses to antihistamines. So that being said, what are the goals of treatment? Well, a question should be asked, should treatment aim at complete symptom control in urticaria? And the guidelines recommend aiming for complete symptom control in hives as safely as possible. And this was a strong recommendation followed by the International Urticaria Committee. So what is the need for alternative novel therapies? Because once we get past step 2 therapy, what do we do if these patients don't respond? And here you can see this was looking at patients who are on different combinations of first or second generation antihistamines and leukotriene modifying agents. And you can see that only 38% of these patients were controlled on these medications. And when they were bumped up to other treatments, you can see that 33% were controlled with cyclosporin, but 18.5% required prednisone. So it suggests that there may be an autoimmune issue in this in many of these patients who fail the step 2 therapy, given the response to the cyclosporin. But that being said, the era of biologics now is here for treatment of chronic spontaneous urticaria, and the first one approved for this indication is omalizumab. And in contrast to other alternative agents for refractory chronic spontaneous urticaria, efficacy is supported by well-designed, large, double-blind, randomized controlled trials. It's associated with relatively low rates of clinically significant adverse effects, and therefore, on the basis of these data, the omalizumab made great criteria for an upgrade from step 4 therapy to step 3. Now, there are newer revised guidelines that are coming out in the near future that may modify this recommendation slightly, but the essence and the intent is the same. Now, what's the data look like? Well, here you can see in these studies that both groups, whether this was patients looking at their itch severity score as well as their score for the number of hives. And you can see in both scenarios, the 300 milligrams once a month was significantly reduced, as was the 150 milligram dose. But issues still remain pertaining to omalizumab. It's administered subcutaneously. There is a risk for anaphylaxis, although now the FDA has allowed patients to receive omalizumab at home if they've tolerated it 3 times in a physician's office without reactions. But we still don't know the optimal dose, the frequency of administration, the treatment duration, how to step down over time, and whether that's clear. And when also we do now have biomarkers that help us predict response to omalizumab, and that can certainly impact patient selection. In that we certainly don't want to put people on this therapy, as it is more expensive if we have a high predictor that this may not be the appropriate treatment. So one does need to characterize patients and make sure that they will have the best chance of having an effect when they are started on omalizumab. Now, this is just showing the percentage of omalizumab responders by 4-week intervals, but you can see that for the most part, patients were relatively well controlled after the first few visits, and then it starts to plateau. And this is true of all of the clinical studies. When we look at efficacy in a real-world setting, and this is a systemic review of real-world evidence, again, conducted using 84 reports, case series, retrospective, prospective, observational studies. And again, they conclude there's strong and sustained real-world evidence that a broad range of chronic spontaneous urticaria patients respond to treatment with omalizumab. And also this data translates into significant improvements in quality of life. And the safety profile of omalizumab in this study was in line with results of phase 3 trials in the product label. And this is just illustrating mechanisms of action. As we know, it is an anti-IgE antibody that binds to autoantigen. And this is when patients get desensitized when circulating Ig is very low. And it results in rapid dissociation of bound Ig from mast cells and basophils, lowering the phosphorylation of key molecules mediating secretion. It downregulates Ig receptors within 1 to 3 weeks, as well as preventing cross-linking, and it lowers Ig receptors in other inflammatory cells, including dendritic cells, Langerhans, macrophages, or B lymphocyte subpopulations. So this, again, has broad activity and it has demonstrable benefits for patients with chronic hives. And this is an algorithm for treatment of omalizumab and how one might consider stepping down over time if they're completely well controlled. And there's no specific right way, but this is one system that has been published, which talks about how we can taper or how we can taper down after patients are shown to be well controlled on this medication. Now, cyclosporin, what happens when omalizumab doesn't work? That would require medicines like cyclosporin, which is an immunosuppressant that inhibits multiple cytokines production, as well as nuclear factor kappa beta, NF-kappa beta. The toxicity requires monitoring of blood pressure, lipids, and renal function. And in one double-blind placebo-controlled trial with 4 milligrams per kilogram cyclosporin revealed that there was improvement in daily urticaria score by 12.7, and histamine release also decreased from 36% to 5%. And also the autologous serum skin test was reduced in responders. So the studies like this have raised cyclosporin as a step for recommending cyclosporin as step 4 treatment in both international and U.S. guidelines. And it is a consensus recommendation for both guidelines to have this as a step 4 therapy. Now, there are a number of other alternative therapies, including anti-inflammatory agents, and these agents may be generally well tolerated, might be efficacious in properly selected patients, and can be considered for treatment of patients with antihistamine refractory hives. But again, there's weak level of evidence based on grade methodology. These agents have not been included therefore not been included in the international guideline with the main treatment algorithm. And this also is discordant, as the Europeans don't the international guidelines does not recommend alternative therapies, whereas the United States Joint Task Force does still feel that they may have some benefit in controlling hives in some scenarios. Now, these are the alternative therapies with low evidence based on grade methodology that are listed in the international guidelines, but not in the main text, and things that have been shown to have some benefit for urticaria over time. But now we're getting to the point where we are understanding the pathogenesis and able to keep up with more specific drug development. Now, there's a number of promising drugs in chronic urticaria that target T and B cells, mast cells, eosinophils, basophils, and they all are working on cytokines that regulate these responses and finding ways to either block these responses on the mast cell or some other pathways that could help control chronic urticaria safely in these patients. These are the clinical trials. Most of the clinical trials that are ongoing with chronic urticaria, looking at different dosings and targeting different receptors. And again, we should have quite a bit of data coming out in the near future on how these therapies work. Now, let's again, in summary, I think when we see patients with chronic urticaria, we want to phenotype the patient. We want to educate the patient about chronic spontaneous urticaria in clinical course. We want to perform limited diagnostic testing, but now we may want to include some tests that might be predictive of treatment response or lack of treatment response. Shared decision-making treatment approaches. We should educate patients about expected treatment outcomes, and they should be regularly monitored at each visit for disease activity, severity, and quality of life. It's important to maintain good communication channels with the patient to reduce anxiety and frustration, which especially in initial therapies that are ineffective. And finally, we should manage comorbidities associated with anxiety and depression, which have been demonstrated to be increased in patients with chronic spontaneous urticaria. So I'd like to stop here and thank you for your time. Have a good day.
Thank you very much, Jonathan. And we have several questions regarding your presentation, and I can just pick up one or two questions. First one is for the definition of chronic spontaneous urticaria. Is the length for continuous 6 weeks or any 6 weeks? That is the question. Jonathan, please.
It's just continuously for 6 weeks or longer.
Jonathan. And,
Continuous.
we have several questions regarding. Okay, thank you very much. And regarding the guidelines, difference between European and also Americans. The big difference is probably a recommendation of leukotriene receptor antagonist for the treatment of CSU. Of course, you rely on Americans, and could you give us some explanation for the difference between those two guidelines regarding leukotriene receptor antagonist?
Yeah, it's largely due to the fact that there's just the studies aren't as well powered and they're not as well designed to really make the recommendation based on grade methodology. But there may be clinical relevance in some populations that warrant their use, but just couldn't make the grade method. So that's why they're not included in the international guidelines in the algorithm.
Okay, thank you very much for great talks and also Q&A, even though you were on the way to airplane.
Apologies. I'm on my way to Idaho.
Okay, and let's move to the second part of the urticaria session, and we are going to have management of urticaria in adults by George Watercanonica from Italy. He is going to talk about different types of urticaria, causes of urticaria, and fexofenadine in urticaria, 3 clinical trial cases. George, please start your lecture. Thank you very much.
Dear colleagues, it's a great pleasure for me to be here as part of this webinar. And so I have to thank the World Allergy Organization and, of course, its president for this kind invitation. My task today is to talk about management of urticaria in adults. Of course, my disclosure of interests first. And then let me start with the guidelines. Why? Well, the story of the guidelines started 15 years ago when we prepared this first document, Iaki-Galen, using the evidence-based medicine approach. Then we opted for a new methodology to prepare the guideline. Why? Because the process was to switch from the traditional evidence-based medicine to GRADE. GRADE is grades of recommendation, assessment, development, and evaluation. A more concrete and complete method for making a recommendation. Why? Not just based on the evidences, which of course are important, but also in balancing the evaluation between desirable and undesirable effects. And then the quality of the evidences, of course, are important, but a crucial role is played by patients' value and preferences. And finally, also the costs are important. So it's a more balanced way to make a recommendation than what we did with the evidence-based medicine, just going straight to the recommendation having the evidences of the randomized study. Let me give you an example why this is important. Because in urticaria, of course, quality of life, which is one of the patient's recorded outcome, is indicating that the normal activity, the normal daily activity is restricted, that the sleep, mobility, and energy is damaged, and increased pain, social isolation, and emotional distress is present too. Finally, the quality of life reduction is similar to patients with heart diseases. Well, all this has a cost. And in fact, we can observe that there is a decrease in terms of work, school productivity, and performance that is between 25 and 30%, which is having a social cost. And that's the reason why first area in 2010 and 4 years later for the urticaria, we switched to grades. Now, this is the example with the picture showing us voting the consensus to be reached for this 2014 publication about the Iaki-Galen EDF WOW guidelines concerning definition, classification, diagnosis, and management of urticaria. Well, I have to say that a few years ago was published this paper, which I think is very, very important. Why? Because they claim that a true worldwide agreement was published in 2018 and should serve as the consensus document on the diagnosis and management of chronic spontaneous urticaria. And that's the reason why I will base my talk concerning the guidelines on this one, which is the paper was Sanchez Borges was talking about in the previous publication. And this was the last revision published in 2018, where the subtypes of urticaria were described. I'm talking about the chronic spontaneous urticaria, differentiated by the 6 weeks presence of wheals and other symptoms, and then the inducible urticaria that might have different agents inducing it. But also the algorithm of the wheals to reach what is the chronic spontaneous urticaria, or the urticarial vasculitis, or the inducible urticaria. On the other side, you have angioedema. Then, there are, of course, the diagnostic tests, and here are reported both for inducible urticaria, and then you can see that there are, in some cases, there are possibility to induce and to have the tests to identify this disease, or for acute spontaneous urticaria, which is not the case, and for chronic urticaria, of course, you have the typical evaluation, the clinical evaluation, which are very, very important. As I mentioned before, it's important also to have using, for instance, the urticaria activity score, an evaluation as far as the severity of the disease, being known, mild, moderate, or intense. But the burden of the disease is also related to the impact of the quality of life, and we described, and this is a part of the international guideline, the CUQ2OL, which is the specific quality of life question. Let me report that this paper was published more than 15 years ago. And this was also part of the recommendation that the Galen Task Force published for evaluating the patient's reported outcome in urticaria. And as I said, is nowadays also in all the guidelines. We also transformed this in a validated tool that can be used in clinical practice. So in your daily practice, and this is, of course, another important issue. And we also published what is the minimal important difference that you can evaluate easily using this question. An update about the documents came just last year by the CIA, the Collegium Allergologicum. And once again, as far as PRO is concerned, as you can see, quality of life has different tools that are available in quite a lot of different languages. And this is making, of course, the document of 2018 very, very useful all over the world. Let me give you an idea about what we did in Italy. Why? Because I'm going from the world to region, and this is to country. Why? Because together the Society of Allergology and Dermatology, we combine the treatment of this issue, this disease. And then we reported, of course, once again, what are the types of urticaria and the causative agents, what are the questions that should be addressed to the patient, and also the scale of severity. That was exactly what I mentioned before. In addition, what are the main provocation tests that you can use in the inducible urticaria? And and also the laboratory tests that you can use. I have no time to go into details, but there are all the references. Now, I think that it's important to have a worldwide perspective. We went to the different countries, but what is the reality all over the world? I think that this paper is quite important. Why? Because first of all, you're saying that almost all the caregivers, mainly the physicians, that are taking care of urticaria, they are following guidelines. And in the world, 60% of the ones that are treating urticaria, they are following the IACI-Galen WOW guidelines, the one that was declared as the consensus document to be used all over the world. Now, very recently in the WOW journal, there appeared a couple of papers of interest, because talking about making an update about some aspects, including the one concerning treatments. Well, in the first document, there was a new, let's say, algorithm as far as the classification is concerned. But it was important also to start talking about clinical phenotypes. And in this case, it was the definition that was acute, chronic, inducible, or spontaneous. And then for the first time, probably, no, I mean, in any case, it's important. Nowadays, we are talking a lot about endotypes in different diseases. Here again, I mean, it was reported different endotypes. Let me go ahead with the treatment, because this last point is also related. In the first document, it was important to talk about first-line treatment, non-sedating antihistamines. Then, if not working enough for sufficiently, after 2 weeks, switching up to 4 times the dose. If symptom persists for 4 weeks, you can add an anti-leukotriene, and then if there is an exacerbation, the systemic steroid, and then if the case, you can switch to cyclosporin, dapsone, omalizumab, and so. This is the 2018 view. First of all, let me go on the left side, and I think that this is very, very important. Why? Because 90%, so more than 90%, there was an unanimous consensus about the recommendation of second-generation antihistamine as first-line treatment in chronic urticaria. And this is evidence-based and consensus-based. And for instance, the other point is that should water-generation antihistamine be taken regularly or as needed by patients with chronic urticaria? And once again, there was a consensus for using them regularly. And what about the treatment? Well, once again, second-generation antihistamine, if not working, increasing the dose up to 4 times, and if not working for 4 weeks, and this is changed, then add omalizumab. If it's not working, switch to cyclosporin. Now, I think that this is another very important point. Think about the first draft, the first guidelines treatment. Here we recommend against the long-term use of systemic corticosteroids, and with a very great consensus, whereas a good consensus was the use of the short-term course of systemic in case of acute exacerbation. Now, I was talking about the endotype. And Markus Meurer very recently was talking about endotypes. Endotypes means different mechanisms inducing urticaria. And so there is an allergic mechanism that is known. And then, let's say, an autoimmune, which means IgG anti-IgE or IgG anti-Fc epsilon receptor, or so-called autoantigen. And on the other side, this means that you might have the need of different kind of treatments. And Sanchez-Borges actually define all the new possible potential targets, you know, some of them already we know and we are involved in trials. And these are the drugs that are currently under investigation for the indication of the new drugs, new biologics, for instance, under investigation for chronic urticaria. And here the potential targets are defined in a different way. Nonetheless, let me go back to one of the key points of the treatment, the antihistamines. First of all, let me make you aware that nowadays we are always talking about evidence-based medicine, considering the randomized controlled trials, which of course is still the basis of the evidence, but is possibly not fitting with the clinical practice. Why? Because we selected the patients, as you can see here, for randomized controlled trial. And we avoiding, for instance, comorbidity and other stuff. For instance, in asthma, at the end of the story, it was calculated that you can enroll 1.5% of all the asthma patients, which means that there is a clear-cut difference between the ideal patient that you have in the randomized controlled trial and the patient that you have in front of you every day in your clinical practice. We summarized it in a paper that we published very recently in Allergy as position paper of the methodology committee, showing that when we are talking about efficacy of a treatment, we are talking about this small population of the randomized controlled trials, whereas when we are talking about effectiveness, we are talking about the data that we can collect in real life, because the populations are different. And we also, this was related to allergen immunotherapy, but nonetheless, we proposed a new hierarchy of the real world evidences. In that, I mean that the pragmatic study, registries, prospective and retrospective, and experience, expert evidence are the different degrees of evidences, and then we hopefully will integrate with the grade system. Now, why I'm talking about that? Because, for instance, this study is a real-world study, and is the first real-world study that is examining the economic and humanistic burden of chronic spontaneous urticaria. And this was involving several countries in Europe with a lot of patients, and defining, of course, what are all the, let's say, all the evaluation, including the costs. And for instance, this evaluation that is coming, of course, is important for also giving an idea about the cost. This was also related to Italy. And of course, the indirect cost for a week in our patients was really quite impacting. Now, let me go back to another real-life experience in solar urticaria, and this was a retrospective study. Well, as you can see, the antihistamines were used, and the conclusion was that a complete remission of symptoms can be achieved in most patients with the solar urticaria under treatment with antihistamines. But when I spoke about the real-world evidence, I was talking about registries. And our colleague Maximilian Gomez published in the World Journal an editorial that was important. Why a registry for chronic urticaria? And then he set up a chronic urticaria registry in Latin America, who contributed to understand, for instance, that pruritus was very impacting, having just 12% of the patients with no pruritus. And as far as anxiety is concerned, having really a great impact in patients with chronic urticaria. And finally, I mean, as far as the efficacy of antihistamines, actually is important to understand that just 10% of the patients were non-responsive or not controlled with this kind of treatment, whereas the vast majority of them was susceptible to the effect of the antihistamines. And in fact, also, as far as vasculitis urticarial, I mean, Marcus Meurer and his group, he published that antihistamine and standard dose are first line, and the up-dose treatment is second line also for this kind of disease. Let me now switch to fexofenadine. Why? Well, first of all, because fexofenadine has a very rich literature. More than 100, almost 150 papers if you put fexofenadine and urticaria. Well, let's say a little bit less if we are talking about adults. That is the topic I have to talk about today. And for this reason, I went back to studies that we published more than 20 years ago, because I think that this was important. Why? Because we demonstrated that fexofenadine was able, more than terfenadine, and of course much more than placebo, to down-regulate adhesion molecules on epithelial cells. And this, of course, was an anti-inflammatory effect. Anti-inflammatory effect that was also confirmed in the reduction of IL-6 production by epithelial cells. And this is, again, even when stimulated with the gamma interferon or TNF. So this was the first demonstration that the downregulation of ICAM1 and the downregulation of IL-6 was showing an anti-allergic activity of fexofenadine. This was also confirmed by a study that we published a few years later in the Journal of Allergy and Clinical Immunology. Now, let me go to Japan. Why to Japan? Well, first of all, you have to understand that in Japan, this was a comparison between 120 and 240 milligram a day, but they are usually having 60 milligram that they have to double every day. Now, the point is that they demonstrated the clinical efficacy, and as you can see, is dose dependent as far as the visual analog score is concerned, or the severity index of the chronic urticaria. Now, I think that this is quite interesting. Why? Because they used also the histamine-induced wheal and flare, and this is what we can observe with the two different dosages I mean, on the skin of the treated patients. And here, of course, there was the possibility to evaluate in a more interesting and sophisticated way. But the results are very important. Why? Because this was confirmed with the different dosages and in function of time for the flare, for the wheel, for the area in centimeter, but also as far as the itch is concerned. And so the conclusion is that the double dose of fexofenadine treatment suppressed the skin symptoms more rapidly, profoundly, and sustainably than a conventional dose of fexo treatment. Now, a systematic review of the updose. Well, I reported here all the double-blind placebo-controlled study that was considered in this systematic review. I wish to stress one point. The number of patients recruited in these double-blind placebo-controlled trials are quite remarkable. But then there are also some other observational studies with not so many patients. Nonetheless, the effect was very, very consistent, and the authors found that increasing dose of fexo to 108 milligram daily achieved better control. The efficacy measures were the mean daily total symptom score, that means prurito score, and number of wheel scores. Now, let me switch to Brazil. Why? Because this is a provocative study that I was interested in. Here, you can see that there was a comparison with the generic of fexofenadine, as for some other antihistamines of the second generation. Of course, there was a difference in terms of costs, but there was also a difference in terms of effect on the wheel and flare induced by histamine. So we should keep it in mind. We will come back on this. Why? Because, of course, I need to conclude talking about the safety. And as far as I know, there are no meta-analysis studies in urticaria for the safety, but we did a meta-analysis for fexofenadine in allergic rhinitis, and as you can see here in the forest plot, there was no difference compared to placebo. Now, another study, that this is a double-blind placebo control on the effects of fexo, was demonstrating that it was absolutely correct without disruptive effects on psychomotor aspect and cognitive function. And the Brazil back. Why? Because if we are talking about drowsiness, you will see that fexo is the only molecule that doesn't have any effect on that. Whereas in some cases, more or less, depending on the first or the second generation, all the other molecules, they had this. What are the key messages? Well, the key messages are that the guidelines of chronic urticaria are consistently used worldwide. The second generation antihistamine are consistently reported as first-line treatment in chronic urticaria guidelines. And fexofenadine is effective and safe and consistently used worldwide. With this, I thank you very, very much for the attention. And of course, I thank also my team in Humanitas University. Thank you very, very much for your attention here.
Thank you very much for a nice presentation of treatment of CSU in adults. And we really understand the guideline by Europeans, and also the importance of the second generation of antihistamine, especially fexofenadine, as the most safe drug for the treatment. And I would like to raise one question for Professor George Walter Canonica. And I got the question saying that is throat irritation not to the level of developing upper airway obstruction a common complaint of CSU patients? Is it possible for you to answer?
I could answer, but could you repeat the question?
Yes. Throat irritation, not to the level of developing upper airway obstruction, a common complaint in CSU patients? That is the question.
In other words, I think that the comorbidity that actually is with the skin is occasional. So, I mean, if you look at the epidemiological data, I wasn't supposed to talk about it, but nonetheless, I can answer to the question. It's not so common. And I can tell you as allergist and a pulmonologist, and for instance, let me say that, and once again, I stress the point of the registries. Why? Because the registries can give you really an impact of what is the reality and what are the real data. Well, if in the registries with the severe asthma registries, I would say all over the world, we are currently discovering that the impact of nasal polyposis is unbelievably high. If we are discovering that some other comorbidities such as bronchiectasis are really almost 25% of our patients. And in addition, if we can add the idea that atopic dermatitis is, you know, about 5 to 10% of our patients. I mean, we don't have such data in terms of impact concerning urticaria. So in other words, I mean, I think that the relations between these different clinical aspects are not so strict, or at least not so frequent.
Okay, thank you very much. The second, the final question for you. What is the maximum dosage of fexofenadine? Either 240 or 540 milligram.
Well, let's say that when you are treating your patient, you should go up 1 tablet per tablet. So paradoxically speaking, usually the 3 tablets, that means 360, or it depends if you are using the 180, it depends on the country. I know, Motohiro, that actually in Japan, you have different dosages. And that's the reason why I would say that 180, 3 doses is usually fine to support it. But we shouldn't forget that 180 is usually the tablet that we use.
Okay, thank you very much, George. I appreciate your great presentation and also presence at the Q&A session. Thank you very much.
Thank you.
So let's move to the next talk by Professor let me share the Sandra Nora Gonzalez Diaz from Mexico. She is going to talk about management of urticaria in children, probably focusing on most common causes of urticaria and also fexofenadine in urticaria and some clinical cases. So please start your lecture, Sandra.
Hi, it is a great pleasure to be here in this webinar speaking about the new insights for the optimal management of allergic disease. Regarding the management of urticaria in children. I am Dr. Sandra Gonzalez-Diaz from Monterrey, Mexico. So, the urticaria is one of the most common skin disease in the worldwide that it is characterized by this kind of itching, wheals, angioedema, and it could be both. Although the urticaria most commonly presents in the children as a just unique episode, could be with several days or all the week. Many of the infants and children suffer from persistent kind of urticaria. As a definition, the wheals can be affected like multiple kind of shapes and with different sizes that could be from 1, 2, or 3 millimeters until 10 centimeters. The central edema is variable sizes with this erythema around it on this kind of this perimeter. The itchy and sometimes burning feeling, this kind of evanescent migratory with the skin with a normal appearance after it's come back and forth disappearance and could have a duration of 24 hours. Speaking about the kind of clinical presentation, the most common distribution of this angioedema includes the face, eyelids and lips, hands, feet, the scrotum, and the mucous membrane, including oral and genitals. What about the acute urticaria in children? The acute urticaria is usually caused as a secondary of viral infection, such as the upper respiratory tract or mediated by IgE, including food allergens in younger children could be like secondary eggs, milk, soy, peanuts, or either wheat. The most common food allergens in other group of older children as a trigger factor reactions include fish, seafoods, and nuts. In children, the most frequent cause of acute spontaneous urticaria are viral infections that includes upper respiratory, gastrointestinal, and urinary tract infections like adenovirus, enteroviruses, rotavirus, respiratory syncytial viruses, Epstein-Barr, or even cytomegaloviruses. What other causes we can have as acute urticaria in children? It could be like drug hypersensitivity to non-steroidal anti-inflammatory drugs, and including antibiotics as well insect bites such as mosquitoes. What about chronic urticaria in children and in pediatric is defined by the daily presence of this kind of wheals that may not always be associated with angioedema for over 6 weeks or with brief period of time of will being due to the treatment. The prevalence in children is estimated less than 1% and no significant difference among female or male has been found until now. In children, the CU, chronic urticaria, has been classified as either spontaneous or inducible, depending on whether or not the trigger factor has been identified or not. According with Nechparot, NCOLs, the most common type or spontaneous or inducible in 78% of the cases, while 22 represents the physical ones. As we can see here in this table, the classification of chronic urticaria subtypes represent the presentation with wheals, angioedema, or both, recommending diagnosis tests. We can see here the inducible triggers like symptomatic dermographisms, cold urticaria, could be delayed pressure ones, solar, heat urticaria, cholinergic, contact, or aquagenic. And according with the diagnostic program, we can have asking the provocation test with the cold, with the ice cube, or with the light pressure urticaria with pressure test, with a special weight bags or a special instrument on the arm, or the solar with sunlight to buttock area, or heat urticaria with metal or glassed cylinder filled with hot water, or vibratory angioedema with vortex mixers for at least 10 minutes, with cholinergic with physical exercises to the point of the sweating or hot bath, contact urticaria with open test with suspected substance, or with the aquagenic with attaching compresses with water on the forearm for at least 20 minutes. What about the pathophysiology? Well, with the endotypes of the urticaria induced spontaneous are activated in most of the patients with autoantibodies by IgE to autoallergens mediated by type 1 of autoimmunity, or either IgG autoantibodies targeting activating the receptors MC with the type 2B autoimmunity, as we can see here in this slide. The mast cell activation in acute and chronic spontaneous urticaria, we can see here in this figure that we have the spontaneous urticaria with this thyroid and nuclear other self-antigens binding to the autoreactivity antibodies IgE, or we can see here in this side the acute allergic urticaria with foods, drugs, venom insects binding to this allergy-specific antibody IgE with the mast cells, or we can see here the urticaria produced by the releasing of this histamine in particular, but other mediators as well. On the other hand, for the diagnosis of urticaria, the following questions we always should be considered, like when disease started, the frequency of the duration of this kind of lesion and the trigger factors, the daytime variations, the presence related to the kind of trips or weekends, the shape, size, or distribution of the wheals, the related angioedema is associated with pain or pruritus, the correlation with exercise, food, menstrual period or physical triggers, the use of medicines and supplements, or what kind of prior treatment and response of that. What we can say about the differential diagnosis? Well, in children, the urticaria commonly presents as one-time acute episode that might last 2 weeks, and a small proportion of these patients are reported to progress to a chronic form of urticaria. The differential diagnosis in pediatric patients includes anaphylaxis, viral infections, and serum sickness-like reactions. This differential diagnosis of acute urticaria in pediatric patients, like anaphylaxis, is up to 80% of the patients that presents the urticaria as a clinical features, and epinephrine, as we already know, is the indicated treatment when at least 2 of the organ systems are affected. Speaking about the viral infections, might be associated with urticaria multiformes, that is self-limited conditions that resolves this kind of infection improves. The SSRR, the serum sickness-like reactions, it's kind of ecchymotic centers with a kind of large plaques, urticarial plaques, where hands and foot are swelling that may be involved, as well as fever, kind of abdominal pain, headache, diarrhea, that presented at least 1 to 3 weeks after to be exposed to this kind of certain kind of drugs. The antihistaminic, antipyretic, in some cases oral steroids, should be included in the initial management of this kind of SSRR and urticaria multiforme. What kind of chronic, this kind of chronic urticaria require tests? We should think about it. Well, in this kind of chronic urticaria, we should require a complete blood cell count and sedimentation rate, C-reactive protein levels. In most of the cases, the only test required. A type 2B autoimmune origin is presented in up to 40% of the adults and in children with chronic urticaria. And supposed to be that kind of autoantibodies induce basophilic and mast cells degranulation. The chronic urticaria required test, the autoantibodies either with the use of the autologous serum skin test or with the basophilic histamine release assay may be used in this kind of patients. The identification of these potential triggers when it is possible and their avoidance is the first step in the management of these patients with urticaria. Well, in these algorithms for the diagnosis of subtypes of urticaria, we can see here the average of the Wells durations, more than 24 hours, the vasculitic skin biopsy, it is necessary, or the delayed pressure that is a specific diagnosis test. Here, if the average well duration is less than 24, if the patient history and physical examination suggests that these kind of lesions are inducible, the physical specific diagnosis tests, this is due to the food or drug skin test and specific serum IgE, we can perform the provocation test, or if the specific laboratory test requires a recurrent isolated test for complement, C4, C1, INH level, we need to perform gene mutation and analysis for the hereditary periodic fever syndromes like Crypyrin-associated periodic syndrome, if we strongly suspect of that. But if this is negative, we should make a differential diagnosis count on that and diagnosis test for celiac diseases, for instance, or any kind of thyroid disorders. Okay, what about the treatment? The second generation antihistaminics remains the initial treatment of choice. The doses of this second generation antihistaminic should be increased up to 4 times for the trial if the standard doses it is not effective according with the WHO guidelines. The second generation antihistaminic in pediatric ages, we have here cetirizine according with the age or weight, and these are the dose, levocetirizine, fexofenadine, desloratadine, loratadine, bilastine, and rupatadine. The treatment in children and first line is the second generation antihistaminic in a standard dose. If this is with a no good control, or if this is inadequate, after 2 weeks or earlier, or if these symptoms are not tolerable, we need in the second line and less than 12 years, we need to increase the second generation doses up to 4 times, as I already said. And if they are older than 12 years, we should start to thinking about add monoclonal antibodies to this second generation antihistaminic. And in the case that they are not well controlled or inadequate after at least 6 weeks or even earlier, in the third line, in less than 12 years, the second generation antihistaminic plus antileukotrienes or the omalizumab or adding cyclosporine, and in older of 12 years, increase the second generation up to 4 times, or second generation plus the antileukotrienes or at the cyclosporine. Well, the treatment, the cetirizine used in teenagers may cause some kind of somnolence and decrease the desire to be involved in the activities, normal activities. Other second generation that higher than normal doses should be fexofenadine, or could be suggested bilastine or desloratadine. Other future studies establishing the safety or higher doses second generation antihistamine are needed. Effectivity of cyclosporine has been reported in children. We need to take care about the kidney function and blood level monitoring. Maybe, of course, it is a obstacle for the use. The oral corticosteroids are indicated at a dose of 0.5 to 1 milligram per kilogram for 7 to in a short cycle, less than a week, in patients with acute severe flares. The omalizumab in pediatric treatment, large-scale studies measuring the optimal dose and duration of this treatment with this omalizumab in pediatric patients are still required to establish, including them in guidelines, but have been reported that 150 milligrams, 2 to 300 applies once monthly for 6 months, may control most of the cases. We have here some articles very interesting in pediatric allergy immunology about the safety and effectivity of omalizumab for the treatment of chronic urticaria in pediatric patients. In this case, it's almost 40 patients, included with 68.4% used without reported no side effects, good response, achieved almost 77% of the patients, with 1 to 2 years drug survival rate were between 62 and 50% respectively, well controlled. Most frequent reason for discontinuation is in almost 70% of the patient. And we can see here about side effects in less than around 7%. What about the psychological impact and quality of life? In this kind of children with chronic urticaria, we can find the discomfort caused by this kind of itching, the physical aesthetic aspect, and kind of unpredictable manifestations cause concerning about their health. Anxiety, higher risks of depression also are very present in this kind of children. The psychological consultation must take place with a valid and trusted based relation between the clinician, patient, and the family, and must be protected and always be companion. Let's see some quick cases. In the first one, this is a 4-year-old female patient with family history of allergic rhinitis. We can see here that presents generalized urticaria reported an hour after eating a tomato and cheese soup. No evidence of previous or curing infections, no NSAID or antibiotic given. Mosquito bites also were denied. Mother started medication with loratadine, 1.25 milligrams twice daily. Partial response. The patient presented a flare of urticaria 20 minutes after eating a cheese sandwich. Fexofenadine, 30 milligrams twice daily is given with complete remission of symptoms. A skin prick test for milk positive and is recommended avoidance for 6 months. Let's jump to the other case. Number 2, 9-year-old male patient presented with generalized urticaria 3 days after beginning with the upper respiratory infections. This patient had been receiving diphenhydramine, 12.5 milligrams every 6 hours daily for URE in continued and without complete remission. Reported feeling very sleepy, unable to finish the school work. Fexofenadine started 30 milligrams twice daily, full improvement. Next case, 6-year-old female, urticaria in abdomen and limbs, 30 minutes after receiving a dose of diclofenac for a sprained ankle, infection, food intake, and insect bites, ruled out during evaluation. They gave him fexofenadine, 30 milligrams twice daily, recommended for full resolution of the urticaria. In conclusion, second generation H1 antihistamine are the cornerstone in this management, and avoiding and aggravating factors are beneficial to reduce wheals and itching. The information on the natural course of chronic urticaria in children is scarce, and the application of the studies from adults to children is quite difficult due to the variation of the intensity. Thank you very much. I appreciate your attention.
Sandra, thank you
Yes.
very much for the nice presentation. And I have received a few questions regarding your presentation. I'd like to start from the first one. And the audience sent us the question, the role of air allergen in chronic spontaneous urticaria in children. Do you usually test for those allergens by
The
in vitro or
yes.
skin prick test?
We
Is
do
the
it-
first.
Depends. We do it in both cases, in vitro and skin test, but we must go to the skin in the first line.
And what kind of air allergen can possibly induce chronic urticaria in your experience?
Well, depends. We have a patient that have a mixed urticaria with allergic rhinitis too, so that's comorbidity, and we have airborne allergens like some kind of weeds, and sometimes we have the kind of we call ortiguilla. That's a kind of a bad weed that the kids are in the camps, or they are in the some kind of farms. So they started with the clinical reaction to that. And in some cases, we have a cross reactivity between some foods and some let's say like ragweed in the patients. So we have seen that a lot. Moreover, when they have a past history since the first 12 months with eczema or with atopic dermatitis, and they going through with foods, and then milk, soy, or egg, peanut, and then go through these kind of plants and cross-reactivity.
Okay, thank you. And the second question is regarding the importance of viral or other type of infection in chronic spontaneous urticaria in children. What is the most common virus or pathogens to induce CSU in children from your experience?
Well, according to what the kind of patient that we see here, we have mostly with virus infection, so that they started with some kind of rash and spontaneous urticaria, and they open with these skin problems before go. Might or might not be with fever before the 48 hours before, but we have mostly first I should put a virus and then pathogens.
How about mycoplasma? Do you have those experience?
Yeah, we have mycoplasmas here, but not that much in our kids. We used to have all the vaccination with that in the kids, so we don't have really a lot mycoplasmas.
Okay, thank you very much.
That doesn't mean that it could be, obviously, but I haven't seen a lot as I can see other kind of viruses.
And one question regarding the comorbidity of chronic urticaria and Graves' diseases, that is hyperthyroidism, can be comorbid with CSU in teenagers. Do you see those patients? No?
Teenagers, I didn't get it. Comorbidity between urticaria and teenagers with what?
Graves' diseases, hyperthyroidism in teenagers.
Hyperthyroidism, yeah, and thyroid disease, let's say, we started to evaluate them in the late teenagers, like 18, 19. Before of that is inconclusive because they can have several symptoms, but they can still be not sure to give treatment about hyperthyroidism in teenagers. We used to after the 19, 20, 21 years. So I haven't seen directly in this age of teenagers with urticaria. Not directly.
Okay, thank you.
Some kind of hormones, yeah, growth factor.
And we also use deuterium receptor antagonist for the treatment of pediatric asthma, probably more than that in adult. And do you also use the deuterium receptor antagonist for the treatment of urticaria in children?
Yes, we do, but mostly after we started with, as we can saw over there with the guidelines, so with the antihistaminic according with the age and the generation, mostly second generation, we started mostly with fexofenadine, and then we double the dose until the 4. I mean, we can increase the dose, but after that, according with the guidelines, we used to anti-leukotrienes, but not as the mono treatment, just after the antihistaminic.
Okay, thank you. And since we do not have Jonathan and Walter, are you still available?
Yes, I am.
Yeah, and based on your presentation, you recommended the usage of European guidelines for the treatment of CSU, right?
Yep.
And
it's not just me. I mean, since these guidelines are the ones that are used all over the world by most of our colleagues.
Yes. So we definitely recommend to use the European and GEREN and WHO guideline for the treatment of chronic spontaneous urticaria. And I actually received which guidelines should we follow regarding the treatment of chronic spontaneous urticaria, both in children and also adults. So that answer is quite clear, right?
Or let's say, since I'm talking with the president of the World Allergy Organization, and since the guidelines we are talking about are signed by the World Allergy Organization, the answer is very easy. Yes.
Thank you. All right. Okay, so we have all answered to the questions which I received so far, and I can give you maybe last minute for both of you to give one more key message to the today's audience of this webinar. So starting from George, please.
No, I think that I can do it. Sandra first. Of
course.
Ladies.
So sorry.
Come on.
Sandra, you should be the first.
Appreciate it. Thank you. Appreciate it. Well, what can I say? That's very important to take in account that We should follow the guidelines, moreover, WHO, and as we also have the European. But in this kind of kits, we must remember that we have a lot of expression of the allergic disease that is not only looking for the skin. We need to see them, all of them. I mean, we need to see the back history of rhinitis, asthma, or also the environmental control. It is very important. People with have smoking, even if it's not directly, we have expression in the skin. So, and to use the right antihistaminic and started the dose that we already did it and told about in practice. So treat them as in a integrity, as medicine-based, as a tailor-made it for themselves also.
Okay, thank you. Walter, please.
Well, I wish to follow what Sandra was correctly saying. And what we are currently facing for severe asthma is something that I wish to extend, as in the document we were talking about, the 2018 one, and is the referral of patients to the allergy centers. Why? When I'm saying allergy center, I mean if the case to the multidisciplinary centers. I mean, I wish to include, of course, also our dermatologist colleague. And in that, I mean that actually for having the most correct and updated treatment, the patients, if the situation is not resolved by using the usual dose of antihistamine, should be referred to the center for a correct diagnosis and for a correct and updated management.
Thank you very much. I do appreciate your presentations and also the presence at Q&A session. Thank you very much. Finally, I'd like to mention about our next webinar series scheduled on 22nd October, Precision Allergy Molecular Diagnostic Applications, PANDA. That is our scientific committee is also involved in the webinars. So please prepare for the next opportunity to participate in WO webinar series. Thank you very much for speakers and also delegates who participated today's webinar series by WO. Thank you very much. Thank you.
Thank you very much. Appreciate the attention. Congratulations to each of one. It was a great webinar, great talks. Thank you so much, President.
Great, guys. Thank you very, very much. Bye.
Thank you. Bye.